Well, let me be one of the first to welcome many of you chiefs and future chiefs to our 2021 SAEM Chief Resident Forum. We are so very excited that you guys have joined us today. Again, I encourage you guys to come off at least visual mute as much as possible. We totally understand there will be breaks throughout the day. If you need to go on mute, that's totally cool. If you need to be doing laundry, that's cool too. That's the beauty of Zoom. It's the only good thing about this forum this year. Well, no, there's a lot of good things about this forum. It's the only good thing about having a virtual forum is you can get other things accomplished while you do this. So let me just briefly, let us introduce ourselves. Carolyn, you want to say hi?
Hi, my name is Carolyn Holland. I'm an associate professor at the University of Florida in Gainesville, and I'm the medical director of our pediatric emergency department, and I'm on core faculty. And I will freely admit that I was not a chief resident. However, I was good friends with the chief resident, and I played one on TV once, and I stayed at a Holiday Inn last night. But I made lots of tough decisions about whether to apply for chief or not apply for chief. And I have so much respect for all of you guys for taking on the challenge of being a chief resident, because being in that middle manager role, which I know Dr. Davis is going to talk to you about in just a few minutes, is very challenging. It's a big step up. Acting leaderly and being in management are actually kind of two different skill sets. And so we're excited to have you here. Dr. Stull and I have been hosting this presentation, what do you call it? Workshop for a number of years now, and we've got a great set of speakers lined up. So so thank you so much for showing up, and I'll hand back to Dr. Stull.
Woo, Dr. Hollins.
Thank you. So you got like a woo section already. That's impressive. Or you've just really, cracked the whip on your resume.
I paid them well.
There you go. Well, welcome, guys. My name is Matt Stull. I am the newly appointed PD at the University Hospital's Case Western Reserve program in Cleveland. And so a little farther away from Dr. Holland, but I am so excited to be here. I think one of my biggest passions is helping chief residents succeed. I've been doing this with her for about 3 or 4 years now. I think we've been doing this together. It's 4, yeah. I was a chief resident at the University of Cincinnati, and that opened my eyes to the challenges of this. I wish either they were doing it, we just were too stupid to realize we should have done this when I was a resident, or it's a relatively new advent, I'm not sure. But we are so excited to sit with you today and really explore the both uniqueness and challenges of being a chief, okay? So let's go over a couple ground rules over the course of the day. First of all, none of the speakers have conflicts of interest. They all just love to mentor and support chiefs. They are amazing educators. No one pays anyone to lead and mentor, apparently, unfortunately, so no conflicts of interest. That said, we will encourage you, you get what you put into this, right? We usually have this be like an 8-hour day. We've really tried to be thoughtful about the Zoom format and abridge it just a little bit so that it's not so painful for you guys to be sitting all day, even in your own offices. But please try to engage as much as you possibly can. We don't mind if you're outside. We don't mind if you're walking around, but try to engage with it so that we can hopefully get something really useful out of it. And then the other thing is use the chat. I tried this last night in one of the other sessions, and guys, we're emergency medicine. We're used to doing 2 things at once. And so I do believe that you can actually get something out of listening, but also chat it up. Feel free to use the chat. Dr. Holland and I will be sort of facilitating conversation in there as the day goes on. This is the schedule of the day. We've got 4 incredible, amazing speakers for you. We've vetted them over the years and really picked some of the best leaders, program leaders, department chairs, and just former chiefs who can talk to you thoughtfully about some of the biggest challenges facing you as chiefs. Now, you'll see we did have to make some tough sacrifices this year about content in this one abridged day. So there are 2 topics that we're going to be covering longitudinally. So we'll send out some invites to you later in late May and early June. We'll get you those dates soon about 1, how to deal with the problem resident, which Dr. Snow from Loyola gives and is an incredible talk. You're not going to want to miss it. even if all of you can't be there that day, I encourage you to at least designate one of your co-chiefs to get there.
I'm going to chime in and say, Dr. Snow has an amazing Scottish accent. So even if you don't want to listen to the content, just listening to him speak is so soothing and therapeutic. So you definitely want to show up for that one.
I always say he's the PD I want to be, mostly just because I want a badass Scottish accent, but I just can't do it. And then the other one will be on recruitment, and we'll talk a little bit about virtual as well as in-person recruitment and how to optimize that later on as well, okay? So a couple things just to say, which is chiefing is probably one of the most unique positions of your life. It is certainly one of the most unique leadership positions that you're ever going to be in. It is a great opportunity to lay a foundation for the rest of your career, whether you're headed into academics or you're headed into the community. No matter what, leadership is a core competency of what we do in emergency medicine, and nothing will prepare you to be a better leader than the year that you're about to embark on as a chief resident, okay? And so utilize this opportunity to be really, really thoughtful about how we're gonna go about the day. And one of the things that Dr. Holland and I like to do is, promote a little discussion, really get those brain juices moving. I think that's called CSF, if I remember correctly, but I'm getting farther and farther away from the clinical side. So we're gonna ask you a couple thought questions as the day goes on. There's a ton of you here, and so we're not always going to be able to unmute, but I'd love for you guys to throw some thoughts in the chat. And I really do want you to write something down for some of these questions. So as you begin to think about being a mindful leader, what's the thing that you're most anxious about becoming a chief resident? Go ahead and throw that in the chat.
People are slow typists, so we're going to use what is educationally called wait time, which you might not have heard of. But when you ask a question, you need to make sure that you give the people who are going to respond adequate time to actually think and then respond before people like us who think really fast hop up and answer the question and no one else has had the chance to even process the question. So I'm filling up the wait time with noise, but there, yay, people are typing, woohoo! So the things that are being brought up are managing issues and complaints from peers. That is always hard, especially when you're in that middle managerial position of trying to represent the faculty side to the residents and the resident side to the faculty. Matt's too busy reading and nodding his head.
Yeah, sorry. Yeah, I facilitate. That's right. And I think I've already seen a lot of people say that peer relationship, right? You are just one of the guys, one of the gals, and now suddenly you're in a middle management position. That is well worth some anxiety. Trust with your peers, absolutely. Middle management is what I'm hearing people say, right? That liaison. I am a resident, but I'm not really a resident anymore. I'm an attending, but I'm not really an attending, but you face both. These are all super big challenges for you guys. Good.
And I see a fair amount of wellness concerns. And we have a whole session on that with Cynthia Price at the end of the day. And her talk is phenomenal, like off the chain phenomenal. So there's gonna be lots of resources for you there. And also, hopefully you'll have kind of maybe even virtually connected with some folks here. That's one of the disadvantages of Zoom is that you can't really, sit next to somebody at a table and chat during the breaks, but you can, private chat during the breaks.
Great. Okay. So my second question to you all is, what's the thing that excites you most about this? Okay, so we started with Debbie Downer, right? Okay, there's a lot of anxiety going into this year, but honestly, what are you most excited for? What are you gonna really sort of change, innovate, grow? So change agents. It's not surprising that emergency medicine residents like to be agents of change. That is definitely a key piece to being the chief, is it actually enables you to be empowered to make changes to your local residency programs in ways that, aren't often empowered to a lot of residents.
And having that forward thinking attitude as opposed to, I want to, just kind of maintain the status quo or make sure nothing goes badly is going to really help you keep that fire in your belly throughout the entire year of being chief, when you have a goal that you're heading towards as opposed to something that you're trying to run away from. Somebody with motivation to grow as a leader. Well, luckily our first speaker, who's going to be up here in just a few minutes, is going to talk to you about leadership, and his talk also is amazing. Like Dr. Stull said, we have picked the best of the best from around the country in residency leadership to give you guys some insights to help kick off your chiefdom.
Perfect. So you've talked about the things that are external to you, that are exciting, that are maybe challenging, that are anxiety provoking. The last question I have for you guys, though, is what makes you special? What makes you, what's the one strength that you have that makes it possible for you to succeed, right? So invest here in your strength and really think about this. No one's willing to start the humble brags. It's okay. I'm asking. It's okay.
And when we collect this information that we may curate and send out to you, we're not going to put down the name and say, yes, I, Carolyn Holland, am amazing, but I am, but I'm not going to put it in the chat. Thick skin, that's really, really important. Remembering, and that's anytime you're a leader, you can't please everybody.
I love it. Humility, that's a great one. Being humble as a leader is a key part of working in a team of your co-chiefs, as well as the team that is the residency leadership team.
I like resiliency. That is really important here. I think thick skin and resiliency have a lot of overlap. One is more aggressive sounding and one is more not aggressive sounding, but they are very much the two sides of the same coin.
And then the connection. I think the connectedness that you all have with your peers is going to be vital for you going forward to leveraging that. So I think that's a good way to get us started, thinking a little bit about how we're going to be effective leaders today. And so with that, I'm going to stop sharing so that Dr. Davis can share his screen. And I have the pleasure of being able to introduce John Davis, who, after I feel like a decade of working together, has become a dear friend, but also just an amazing model of a thoughtful academic leader who is going to really frame for us the discussion about chiefing in context of this sort of role as a leader. So take it away, John.
Great. Well, thank you so much, Carolyn, and thank you for that kind introduction, Matt. It's always great to be with everyone. I wish we could be together in person, but Zoom will do. We'll try to keep this as interactive as possible, knowing the confines of Zoom, but please feel free to use your emojis, use the chat function. It might be hard for me on the screen that I'm looking at to get to all your questions in real time, but we'll definitely carve out some time for questions towards the end. Being a chief is an awesome experience in terms of building your personal and your professional leadership arc, but it also comes with a tremendous amount of accountability and responsibility. I thought that third question, I didn't get a preview of those questions, but I tell you, those three questions that Matt and Carolyn asked of you are so incredibly important. One of my mentors throughout my career has always asked the question, what is your superpower? And asking that question about what is it something that you do really, really well? And also couple that with what is your biggest liability? What is your biggest liability? What is your biggest concern as you're moving into that chief year? I can tell you what my superpower is. My superpower is positive energy. I might not have the skill set, but I got positive energy. I'll try to tackle things in a very positive fashion to the annoyance of many of my colleagues at times. And my biggest liability as a leader is that I am by nature not a confrontational person. I didn't go into medicine as a confrontational person. I didn't go into EM as a confrontational person. At the end of the day, in leadership, we're going to have experiences that will sort of extend and push us to our penumbra, if you will, of our comfort zone. And that's what this Chief Forum is all about, getting you more comfortable in knowing what your assets are, knowing what your potential vulnerabilities or liabilities are, and really framing and doing work to make sure that you can lead effectively and really maintain that accountability and responsibility while providing a great experience for yourself and for your team. So our practical pearl here, simple goal, be the boss that you would want to have. And we're really going to do a lot of framing and talking about that. We're going to talk about emotional intelligence. We're going to talk about strategies to refine and define your leadership repertoire. And we're also going to talk, super important, about pitfalls. And I can tell you, every pitfall that we're going to talk about, I've made, I continue to make, but they're important as a frame to learn from to move forward. So here's our roadmap for meeting those goals and objectives. We're going to talk about that EQ, or emotional intelligence, for the emergency physician, pearls, pitfalls, conclusions, and then further reading. Again, as Matt laid out at the beginning, zero conflicts of interest of any way, shape, or form, but I can tell you that I'm a ravenous consumer of Harvard Business Review, a lot of literature outside of medicine, outside of emergency medicine, because CEOs and other leaders of Fortune 500, other companies, this is what they talk about all the time. Nothing that I learned in medical school, nothing I learned in residency. And I can tell you nothing that I learned directly through my experiences in building a residency, as serving as a program director, as being an academic chair. No one has ever taught me any of these competencies. So it's really important to look to literature outside of our own. So you might be thinking, this sounds like a bore. EQ. We got an ER doc who's going to talk to us about EQ, emotional intelligence. What does that all mean? Well, at the end of the day, we can all relate to this. Leadership is all around us. We've been exposed to leaders throughout our entire lives. Doesn't matter if it was a sports coach when we were a kid. Doesn't matter if it was a teacher during the time we were in high school. It could be our deans. It could be our chairs. It could be our current program director, hospital administrators. And at the end of the day, everyone on this call is a leader, whether you realize it or not. Even if you are not destined to be chief resident, just by virtue of your degree and your role, taking care of patients, leading clinical teams day in and day out, the fabric of what all of us do, we are leaders. So the important question is, and we'll take a non-scientific poll here, and you can use your emojis, whatever you want to flash up. I'll try to put myself in gallery view so I can see here. But by show of hands, or show of emojis, I should say, have you ever worked with a leader at any point who just doesn't seem to get it? If you could just flash up an emoji, a yes, a no, I see checks, I see hands, I see clapping, I see a lot of hands waving. I can tell you, I asked this question a number of times each year, and every single time, every hand in the room goes up. We've all been exposed to leaders who just don't seem to get it. What's always concerning to me, though, is when I give this to local groups, or I give this at a conference and everyone from my team and my department is sitting at a round table somewhere, all their hands go up as well, which doesn't make me feel great. But at the end of the day, we've all been exposed to leaders who just don't seem to get it. So I just want you to think, just for a minute or two here, about a couple of key characteristics of leaders that don't seem to get it. And I put Mr. Burns. Mr. Burns is one of my favorite nefarious leaders. For those that watch The Simpsons, nefarious leader on television. What are those characteristics? And how can we avoid those characteristics and contrast this with other leaders? By most accounts and all accounts, just seem to get it. They seem to inspire people to do greater things. And so really that inspirational leadership. What are those competencies? What is it that those leaders do? And what can we learn from them? Contrast that with what we can learn from poor leaders and make sure we're not emulating those behaviors. So all of this really brings down us around to this foundational skill, emotional intelligence. I had never heard of emotional intelligence until about 5 or 6 years ago. It's been a concept. It's been out there. It's mostly in the business, the psychology literature. But emotional intelligence is really important for CEOs. It's really important for managers, and it's really important in healthcare as well. The good thing about EQ, or emotional intelligence, we're going to talk about it in the next few minutes here, is that it's something that can be groomed and refined and adapted and molded over time. So all of us sitting here today, all of us, by the reading that we're doing, by the experiences that we get, by making some pitfalls along the way, because the only way that we're going to grow stronger with that growth mindset is actually having pitfalls and having adversity. This is something that we can improve. And it is a marginal factor. And I always use the NFL example here. A couple of my colleagues are sports medicine physicians, ER sports medicine. They work with a lot of the local professional teams, whether it's the Washington Capitals, whether it's the Washington Redskins or the Washington Nationals. And I always hear them talking about the really good teams in any major league versus the really poor teams and the difference between those teams. You look at an average NFL team, those that are at the top of their conference, those that are at the bottom of their conference, they all have exceptional players. They all have the talent, they have the skill set, but the difference is it's a few plays per game. They always figure out a way to win, or most of the time they figure out a way to win. So that's a difference. That's a marginal factor. Emotional intelligence is no different. It's a marginal factor that can have a profound impact in our performance as leaders. Another thing to keep in mind is that different people sort of grow into the role at different levels of experience. Another sports analogy here. I'm not a big Tom Brady fan. I'm sorry for those that are from the New England nation, whatever they call it in New England. I am a Washington football team fan.
Or Tampa. He's in Tampa now.
He is in Tampa. That's right. But years and years in New England and Tampa. I'll be cautious with Tampa there, Carolyn. But I can tell you, I'm a Washington football team fan. It has been a miserable couple of decades for the Washington football team. But you look at Tom Brady. Tom Brady was like a 200th pick in the NFL draft 20 some years ago. But he really rose to the occasion and arguably is one of the greatest quarterbacks, if not the greatest quarterback of all time. So what is it? Why is it that different people seem to excel at different levels of experience? And that's something for us all to keep in mind. And it is pertinent when we look at leaders as well. Some of us have had experience with medical students who were exceptional. They came to residency, had a little bit of trouble. Others have had experience with colleagues during residency who have ascended to attendings and they haven't done, or they have done better than anticipated. So just realize that the growth trajectory for individuals differs depending on situations. But what can we take from all this information about emotional intelligence and apply it to our workspace, leading residency programs, serving as a chief resident? So it's an innate baseline, but as mentioned, can really be shaped, refined, adapted, molded, groomed, and fortified and strengthened with persistence, patience, and feedback. So one of the most important things I can tell you right now is be receptive and always remain receptive to feedback. Feedback will be tough. It will come from your new interns. It will come from your second years, your third years. It will come from your colleagues. It will come from your program leadership. But at the end of the day, that's the only way that any of us can grow. I'm going to play this video. And Matt, Carolyn, if you just give me a thumbs up to make sure it's coming through here.
Since third grade. What are you looking at?
I'm not looking at it.
We're not good enough for you. You look for something else?
No, I don't know.
What are you, big supermodels? Oh, yeah. This is us. Supermodels. What do you model? Gloves? What are you doing? The girl's totally into me. Brad, eat a Snickers. Why? Because you get a little angry when you're hungry. Better? Better. So, ladies, so lose it.
Stacy, relax.
Sorry. You're not you when you're hungry. Snickers satisfies.
So a great example of self-awareness and self-regulation, right? Not exactly. So the point is, and we're going to talk about this with specific pitfalls, you always want to maintain an even keel as a leader. This is one of the foundational tenets, fundamental tenets of emotional intelligence. Here's a grid of some of the domains and competencies. At the end of the day, what's most important to you in your chief role is really this relationship management. You need to check yourself. You need to check others. And how you do that is by positive influence, coaching, mentorship, conflict management, teamwork, and ultimately you hope in some way, as a chief resident, you're able to inspire others so they will bring out their best and bring their A game every single day to every conference, every clinical shift, and everything that they're doing, which ultimately elevates the game of the program, the department, and all of those who work with you. So now let's talk about some specific pitfalls, because to me, it really is all about tangible examples from experience. As I mentioned before, I do not consider myself an expert in emotional intelligence. I consider myself a student. It really is a journey, a trajectory of lifelong learning. And many of the examples I'm going to give you here are precisely and exactly predicated on mistakes that I have made and regrettably continue to make them. But at the end of the day, it's all about embracing that feedback. And I'll share some mistakes that I've made as recently as the past week and some pitfalls, and we'll talk about those. So we're going to do this kind of as like a David Letterman top 10 list here, 10 points and pearls to carry you into your chief year. So point number 1, support those who you empower. Stand by the decisions of others when you have empowered them to do something, and don't undermine. So what does that mean? Look at your role as a chief resident. And let's just pick something that could occur in a program. I don't know, maybe scheduling issues. If you haven't dealt with scheduling issues yet, you're undoubtedly going to deal with scheduling issues. You own someone's life in creating a schedule. Let's say you as a chief resident pen a schedule or a schedule, you send it out, and once in a while, people aren't happy with their clinical schedule. So someone comes to you as a chief resident, as the scheduling chief, and says, I'm not pleased that I have to work more overnights and I have to work more weekends than any one of my colleagues. And then you retreat, you talk to your co-chiefs, you all come together and say, we've done the schedule, we've been as fair, we've been as equitable, we have been as consistent as we possibly can be. Even though some people have a little bit more, some people have a little bit less. We'll balance this out throughout the year. It's impossible in any given month to make it perfectly balanced. But at the end of the day, we stand behind our decision. Now, imagine if that intern or that junior resident or one of your colleagues who was upset then went to the program leadership. They went to one of their trusted APDs or the trusted program director with the exact same complaint, right? Someone's looking and they're going out as many pores as they can to get the answer that they want to receive. And so they go to the program leadership. Program leadership, either the APD, the site director, the PD says, yeah, I hear you. Yeah, you're right. You're working too many nights and weekends. I'll go ahead and change that. So how does that place you as a chief resident? You've been empowered to make decisions. You've made a decision. You've stood by that decision. And now you've been completely undermined, had the legs chopped out from underneath you. Not a great place to be. So why is this important? This is important because you as a chief are going to be empowering a lot of others in your program with responsibilities, whether that's scheduling recruiting dinners whenever we get back to recruiting dinners at some point, hopefully, but just doing things for the program, whether it's curricular and creating didactic conferences, whether it's other components of what you need to operate and make the program tick. You're going to be empowering others. When issues arise, you always want to stand by those who you are empowering, the more junior residents that you are empowering. Now, there's one caveat to this, and that is that there's issues of law and issues of fact. And I can tell you the overwhelming majority of issues that arise, that scheduling example, too many nights, too many weekends, again, it balances out throughout the years, as long as throughout the course of the academic year, as long as it's not too egregious. That's really a gray zone determination. Whenever it's a gray zone, interpretation, always err on the side of upholding a reasonable decision that was made by the person that you've empowered. However, let's say that you realized someone completely whiffed on programs, policies, and procedures, and you have a document that says no, we can't do this. We can't schedule someone to go in this circumstance. That's an issue of law. That's a completely different circumstance. That's the one circumstance where your program director might need to adapt your decision, or you as a leader in the program may need to adapt the decision of others. But what it requires is an explanation. I would love to stand behind you on this. However, we have a policy and this violates our program policy. And the only way that we can remain fair, equitable, and consistent to everyone is to go ahead and follow our program policies. We'll talk more about the importance of those policies and procedures. And so a note to self, make sure that you know your program policies and procedures, especially when it comes to potentially contentious issues, such as scheduling, such as vacations, such as time off. You want to know those back and forth because you never want to get into issues of law where decisions that you or others are making are actually violating program policies. Point number 2. Embracing the difficult conversation. I shared my biggest liability with you from the get-go. Strength, energy, liability, not comfortable with difficult conversations. No one ever taught me how to do it. I've always shied away from them. But at the end of the day, as a leader, it's all about having conversations. And I will tell you that the lack of a conversation is actually worse than a tough conversation. And I'll give you a perfect scenario that encapsulates this. True story. Colleague of mine from medical school, pediatrics, went to a pediatric residency, always had her eye on pediatric emergency medicine, but never was the right time to do a PEM fellowship. Found a job at a health system somewhere in the country, not going to say which particular health system, where she was working as an ED-based pediatrician. She would work with the EM group. She wasn't PEM subspecialty certified. They had a need to have a pediatric presence in the ED. Basically was always backed up by the board certified ER docs for airways and other things, kind of functioned very well in her scope of practice, but loved the ED. So she was ultimately based in the Department of Pediatrics as a pediatrician. They kind of loaned her to the ED to do her work. And she noticed a pain point among her colleagues in pediatrics. That pain point was that most of her colleagues who were primary care pediatricians seeing kids in the office hated it when they had unscheduled visits. Why? Because they had a slate of 40 patients to see in a day. You had sick kids that would come in that needed to be seen. Other parents would be upset because that would delay their appointment time. And she's like, this could be a win-win. I love acute care. I'm working in the ED, and that's where I'm spending the majority of my time. But maybe my colleagues would all benefit from me volunteering to be the sick call person all the time, Monday through Friday, for the pediatric clinic. So true story. She went to her chair of pediatrics at the hospital where she worked, pitched the idea. The chair said, that's a fantastic idea. Let me get back to you in a couple of weeks. Next thing she knows, she gets an email in her inbox that the Department of Pediatrics is starting a new program in which they have a acute care, sick call, pediatrician cover, but that individual wasn't her. The chair never had another conversation about it, just sent out around an email with a different decision. You can imagine how my friend felt. My friend left the organization. She actually submitted her CV within weeks, very successfully moved to another organization a couple of months later, has been happy for the last decade at the new organization. And in speaking to my friend, I said, what was it that shook out there? Like, help me explain. I understand what happened, but how could this scenario have turned out differently? And what she said was very interesting to me. She said, I came up with the idea. Perhaps the chair had the idea somewhere in the back of his or her mind as well. But at the end of the day, I came up with the idea, and what really bothered me is no one had the respect to talk to me about the decision. They just sent an email. And she said, if someone would have taken the time, if my chair would have taken the time to sit me down and say, great idea, I think it's important that our department does it, but I don't think you're the right fit for that role for these reasons. She's like, I would have been upset, but I wouldn't have left. And so it's this whole goodwill, bad faith conversation. I had this come up with a leadership position that we had in our academic orb for one of our positions, sort of a assistant residency director-like position, where it was so important to speak with those who didn't get the nod for that job. We had 6 applicants, 1 spot, because we didn't want to get into a zone of bad faith. That lack of a conversation leads to deeper wounds that are difficult to hear. So no matter how hard that conversation is going to be, look at others, prep the conversation, prep with your co-chiefs, prep with your APDs, prep with your program director, but have the conversation. Because even if the decision is not in one's favor, most will appreciate and respect the fact that someone sat them down and talked to them on the phone, via Zoom, or face-to-face. We'll talk about some of those treacheries of email, which will bring us to point 3 here. Place yourself in others' shoes often. In every correspondence that you send out, every conversation that you have, think about how you would react if someone had that conversation with you, or you received the similar email. And think, if this would cause a reaction in me, it's certain to cause a reaction in others. So therefore, how can I mold this and adapt this to get the same message across in a different way? You have to get the message across. That's when we talk about the accountability, the responsibility. It is your responsibility as a leader to get the right message across. But at the end of the day, how that message is packaged is everything in communication. So I'll give you a perfect example of this. And my wife always cracks up when I share this example. This has nothing to do with medicine. This is an email that I received as a Cub Scout den leader for my son. My son's now 12. This is back when he was 8, 9 years old. I was serving as a den leader, and just for full disclosure, I am not an outdoor person. I like Hyatts. I don't camp. I don't fish. I don't hike. But my wife's like, you got to be a den leader. Just do it for Matthew. So I said, okay, I'm going to be a den leader. I was dutifully going through my den leader activities for a couple of years, volunteer activity. I was happy to do it for my son and for the other kids that were in the group. But one day I was sitting at the table and I got this email from one of the other leaders within the Scouts. And they said, hey, John, this month's advancement deadline was Wednesday at 8 p.m. and it's now Friday, and you still haven't contacted the leader of the group. Were you planning to pick up this month's awards on your own? Since you would need to go to the Scout store to do that, I'm wondering if you want to coordinate with Peter and Jason, the boss's boss, to purchase all of the awards for the month. And I'm CCing the boss here to let them know what a bad job you did. So let's break down this email a little bit. So let's place it in context. And this goes for every single email that you send out to your team members for the entirety of the coming academic year. What is the context? What am I doing when I receive this email as the recipient? First and foremost, this is a busy clinical stretch for me. Busy time, a lot of shifts. This individual doesn't know that, but I know that. It also is a pretty robust administrative baseline. It was a time of year where a lot of different things were happening with the residency, with the academic platform. So there's a lot of stuff going on in my world. And there was also a really thorny personnel issue that we were dealing with at work. Not in emergency medicine, in my GME role for the broader organization, there was another really difficult personnel issue that was taking a lot of bandwidth from a lot of our teammates. And so this is the stretch when I received the email. What was the problem with the email? No opener, right? Doesn't say, hey, John, how are you? Hope everything's going well. Hope you're having a good week. Second, there's shaming. This was due. Are you planning on picking them up? Basically, you have not done your job. I don't care about anything else. I'm just shaming you for doing a poor job. There was use of questions. Again, I think questions are a good thing. Are you planning to do this on your own? But it really had a punitive tone to it. Like, you are not doing a good job. You have failed at your job, and we're really going to look at replacing you in your volunteer position because you're so bad at doing this. Oh, and by the way, I'm CCing your boss. So you can imagine what my response was. I literally was sitting at the kitchen table, received this email, and I had steam coming out of my ears. My first response was to reply. But I'm telling you right now, take down a note, don't reply. Self-embargo, take a breath. Namaste moment, okay? There is no email that requires an immediate reply. I'm going to repeat that because it's a tough one to wrap everyone's hands and heads around. There is no email that requires an immediate reply. And the reason why I say that is with a big asterisk, that any email that requires a reply that is so urgent, don't email, pick up the phone and call somebody. Because if anything is that urgent, you need to call somebody on the phone. Any email can wait 8, 12, 24 hours, depending on the circumstance. But if it's truly an urgent issue, colleague who is struggling, you need to pick up the phone and call. That's not a circumstance to email. So deep breath. So what was my approach to this? For my own personal well-being, how did I approach this scenario? I did not reply to this email. I waited. There is no urgency to this. There is nothing urgent about those Castaway Awards. But what I did do for myself is I crafted an email that I felt would have elicited a different response in me. And I'll share that email. I never sent it anywhere, but I'll share that email with you. So same message, different tone. Dear John, with an opener, thank you for all that you do to contribute to the Scouts. Simple, disarming opener. Think about that with every email you send, whether it's another set of chiefs from another department, whether it's your own team, whether it's your program leaders. Thanks for your support of our program. Thank you for welcoming our interns in the ICU. Now let me pivot and tell you what the issue is, but thanks so much for hosting our learners. I know that you must be super busy, so I wanted to check in with you regarding the status of the advancement awards that were due this week. One important point to remember. Another one, recognition of life as a busy professional. When your team members are not responding to you, the reason why you're all chiefs. The reason why we're all on this call is we're hyper email responders, right? We're good. We're taskmasters. We take care of things. Most of us try to do that all the time, but even all of us on this call, there are sometimes things slip through. Why? Because we're busy. We're in the middle of a clinical shift. We're ending it with a code. We're trying to drive home safely and not be on our phone when we're driving home. There's all these accessory factors. Always recognize life as a busy professional. Then give the benefit of the doubt. You know, I haven't spoken with you in a couple of days. I haven't spoken to Peter in a few days. If you have already forwarded this information, just disregard this email. If you've already sent your schedule request to the co-chief, disregard this email. It's okay. I just don't have the information right now. And look for win-win opportunities. If you were planning on picking up the awards, we'd be grateful if you would do it for all of us, because that would help all of us. I don't know if you're planning on that or not, but that would help all of us. Going further, we stand ready to help you succeed. Let me know the best way to proceed. I'm on a tight timeline here. And if you could contact Jason and very overtly CCing Jason or me today, it would be perfect. I'm not telling you a week from now. I need to know this information to kind of move forth. And thank you again. We're greatly appreciative. So a couple of things to keep in mind here: the opener, the closer, recognition of life, looking for win-win opportunities, and always giving people the benefit of the doubt. Now, clearly, this isn't going to be the email when you've asked somebody something 15 times, but the initial email and even the second email, when you have one of your colleagues who's working in the ICU, they're super busy, always give the benefit of the doubt. And even better, forgo the email if you need to, especially on that second call, and pick up the phone, speak with someone directly. And it brings us to this whole principle of communication. Like, what is our goal in communicating with one another? It's trying to get our message and elicit an outcome, an action, or a behavior that we're looking for. This is our role as leaders. This is our role as chief residents, but it's all about that messaging and how it's packaged that can land us in the gutter. We want to get to that Emerald City. Do whatever you can to stay on your plan. You have a duty and a responsibility, but make sure you don't get sidelined by some of the issues that can come about. And this just brings us to the whole concept of the treachery of e-communications. Intent does not equal interpretations. Emails are two-dimensional. That's why I love picking up the call. I got one of these calls yesterday from one of my team members that wanted to send, they sent me a draft email that they were preparing to send to a more junior faculty member. What I did is I replied and said, give me a call. And I walked them through what my thoughts about it and what I felt the faculty member was really looking for in a response. And I said, no matter how much time you spend crafting this email, I can tell you right now, it's just not going to do it. This faculty member wants to be heard. They want an opportunity to speak with you directly. And your voice inflections, your intonation is going to be so much more powerful. And it just brings us to the point, if you're going to spend 60 minutes crafting an email, stop crafting it. Pick up the phone and call someone. And that's something that took me about a decade or more into my career to figure out. Whenever I'm crafting the magical email that's going to go out, like, you know, if it's that confusing, I'm just going to stop by conference and have the conversation directly. People like to see people when we can be in person, on the Zoom in our current pandemic world, but have the conversation directly. The power of those in-person chats, self-embargo before you hit the reply. I look at this, I was a brand new program director, you know, however many years ago it was, about a decade ago. And I vividly remember being on a ski lift with my kids, and I'm trying to like manage the kids that were young on the ski lift. And I felt my phone vibrating in my chest area. So I pick out the phone and, oh my God, I cannot believe they're planning on doing that. I ripped off my glove and started replying. I lost the glove. I lost a glove on the ski lift. It was a painful trip down when you lose a glove on the ski lift. So the point is self-embargo before you hit that reply. It brings us to these additional issues. CC, use CC. It's good, but use it with caution. When you CC someone's boss, it aggravates them. An exceptional way to aggravate. Do you need to do it sometimes? Absolutely. You will need to CC the program director. You will need to CC the APD. You will need to CC the off-service rotation director at times. But what I do to not make it passive aggressive, I put it in the body of the email. Just as you saw before, I am including so-and-so on this email for their input as well. Or I'm including so-and-so on this email so they're aware of this issue that has arisen. Whatever that case is, Be cautious with CC. And I've been CC'd on emails where my boss and my boss's boss and the head of the healthcare system, the dean of the medical school, everyone's included on there. At the end of the day, it really doesn't get us to that outcome, that behavior, that thing that we're looking to achieve. Beware the blind CC. This just happened to me the other day. I was blind CC'd on an email. I went to reply saying like, yep, I got it, understood. And I replied to everybody. And I was just supposed to be a blind CC. The initial recipient wasn't supposed to know that I was blind CC. Blind CC just confuses me. My strategy with BCCs is to never, ever use it myself. Whenever I'm a BCC on an email, when I'm replying, I actually forward the email, put the recipient's name in there, avoid the BCC thing. Autocorrect abbreviations will always get you into trouble. I'll tell you, my wife's an attorney. She's not very tech savvy. When she got her iPhone, she asked her boss one day, are you available to meet? She didn't hear from her boss for a little bit, so she suggested some days, Wednesday, Thursday, or Friday. My daughter, who was a tween at the time, said, Mom, what are you doing? WTF? My wife's like, well, what's the problem with that? Well, that means quite a different thing. So you have to be cautious with abbreviations, obviously corrected with an OMG. So this brings us to point number 5, managing change. We all know that change is tough, human nature. And so it's important to actively manage the process. I can tell you that I used to think change meant sending out an email. I can tell you that now my vantage point is much different. Change is a multi-step process. We've actually done a lot of work on this in the business literature. Cotter is one of the leading experts in the world on change management. It is a multi-step process. And actually sending the email or announcing the change is just one tiny fraction of this large spectrum that needs to occur to enact change. You have to give people a reason why they need to change. And I'll give you an important example of this in action. So we were making a change several years ago at one of our clinical shops to our clinical coverage, where we had 3 night docs. We were going down to 2 night docs. We were supplementing those 2 night docs with some PA coverage. You can imagine this was a contentious issue. We were used to the way of doing things for a long period of time. So the chair at the time came down to the faculty meeting. It was on a Thursday morning at 7:30 a.m. and said, hey, I've been thinking about this. We've been asked by hospital administration for a number of different reasons based on our volume, showed some graphs and said, we need to change, go down from 3 nocturnists to 2 nocturnists. You can imagine how that message went over with the group. Didn't go over well at all. It was absolutely a brutal meeting, a lot of opinion, no real solutions. That same chair retreated and said, listen, clearly this is not hitting a chord. Let me circle back and let me think about this some more. This same chair, on his own volition, actually came back to the next faculty meeting a month later and said, listen, we need to make this change for these reasons. When you look at the graphs, when you look at our viability over time, we have to adapt as a group. We have to adapt to our surroundings. And so I have some ideas of how I think we can accomplish this, but let me tell you the end point of where we need to get to. What I want everyone here at the faculty meeting to do is to paint out a roadmap or a couple of options for roadmaps to get us to where we need to be. And that's exactly what he did. He said, let's form some coalitions. Let's get groups of 3 or 4, get together. Let's think about this. What it did is it turned everyone from a problem identifier to a problem solver. And if you can do that with your teams, you are winning the game. Your program benefits from it. Your health system benefits from it. And everyone that you're working with on your clinical teams benefits from that. Because at the end of the day, we're looking for problem solvers, whereas the world has a whole lot of problem identifiers. So how do you engage people to make them problem solvers? You make them part of the solution. Engage people. When you need to make a change to the interns' clinical schedules, bring them together and say, hey, listen, we have to do this change for these reasons, better be a reasonable reason. And I want to pull you together, help us think through this, how we can do this so we'll be least intrusive to your daily workflow. But I'm telling you, this is the endpoint that we need to get to. We're relying on this brain trust to help get us there. So the biopsy, the heads up method, super, super helpful when you're trying to get a sense of how a change is going to be received. I can tell you, even things that you think are all positive, we've had changes. I've been part of changes over the last 15, 20 years where everyone's compensation's gone up and everyone's hours have gone down. And it has caused like a whole hullabaloo. And it's like, no, really? Like your salary's going up and your clinical hour requirements are going down. Like what's bad about that? But it's change. And just realize that change is tough for everyone. Learning to listen. Point number 6. I can tell you, this is a picture of me flying around the ED, right? I'm an ER doc. I try not to be too stereotypical of any specialty. I'll put that. But with that said, I'm an emergency physician. I am a stereotypical emergency physician. I listen intently. I tell students, please, like, not the internal medicine history, just like crank it down. Just tell me what you think the problem is. Tell me what you want to do. This is how we're trained. We're trained to think and make quick dispos. But I can tell you that management leadership is not a series of quick dispos. This is a challenge for all of us. We have to change our thinking. What people are telling us to do in the clinical environment is actually quite different than what others are asking us to do as chief residents or leaders, which is to listen, to gather intelligence, to reflect and ultimately decide the best pathway forward. So resisting that urge to hyper reply to emails, again, very few issues need that immediate response, and also avoid getting cornered into snap decisions. If there is one phrase you can remember from this talk, it is, I will get back to you shortly. Just remember that and tell it, I will get back to you shortly. It's important in our responsibility as a leader to recognize when we're being asked a question, to provide a timely response that we're thinking about it, but not to give the answer right then and there. I'll give an example of this in a moment here. So beware of the holidays. Point number 7. Winter's a tough time in the academic calendar. Doesn't matter if it's the academic calendar, the fiscal year. At the end of the day, we all roll from July 1st to June 30th. That's when residency programs start. That's when graduation and promotions to the next level begins. Winter is a tough time. This is a lesson that I learned from one of my mentors very, very early on. So when I first took over as program director, my chair at the time said, John, I'm going to tell you X, Y, and Z, but the one thing that you'll never read in the book is that winter's a really tough time. Why is that? Depends on the part of the country that you're in, but I can tell you in the mid-Atlantic here, it's short days, bad weather. The glimmer of the fresh start in July has faded, and the road to June, when you're sitting there in December, is really distant. The holidays are upon us. Many of us can't spend as much time with our loved ones. Some of us are spending too much time with our loved ones. It's an emotionally charged time of year. But when you're looking at making changes, what's a better time to do it than January 1st? It's halfway through the academic year, right? You reach half the year. It's the halfway mark. But I can tell you it's a really tough time to make change. My general rule, my general principle is no major changes from Thanksgiving through January 1st. You can make a change in the first 2 weeks of January, but that holiday time is not a great time to make a change. This is something that we saw even with the COVID pandemic, with the rollout of vaccines. This is a really great thing, but man, it is a tough time to operationalize something that is so emotionally charged for all of us in so many ways. So really, really tough times, requires additional sensitivity. Be mindful of when enacting and effecting change. And just for the record, the COVID vaccine, it needs to come out as early as possible. So don't wait until January 15th with the new COVID vaccine in any way, shape, or form. Get it out as quickly as possible. But in the process, be very mindful of the emotions and everything that's happening in everyone's plates at the same time. Stepping back from those emotional triggers, this is where I'm going to give you an example of what we were talking about before. So as emergency physicians, we are poised to identify patterns. That's how we roll when we're working clinically. When I'm working clinically and I'm sitting at my desk and we have a team and I see a nurse racing someone back who's holding their side and they're writhing in pain and they're middle-aged, and I'm thinking kidney stone. If they're older, I'm thinking AAA. If they're younger, I'm thinking other things. So I'm automatically starting my differential. I'm looking for patterns. That's how we roll clinically. That's how we're taught to roll clinically. But at the end of the day, when you're doing things from an administrative perspective, you can't just go with patterns. You got to take a step back. A perfect example of this, and getting back to that point I made before about give me some time and I'll get back to you, was graduation. Several years ago in our program, the second-year residents were supposed to plan graduation for the seniors. It was something that happened year after year. But this particular second-year class, many years ago, didn't pick a venue for the graduation. And it was like April, and every venue was already booked. And the third years were really angry. And it's never good as a program director. It's never good as a chief resident when you show up at weekly didactic conference and you see people look at you and then look away. They look at you and then they look away. This was happening at this conference. I'm like, this is not good. I don't know what the issue is. I haven't been briefed on anything. I talked to my APDs. I'm like, is there something going on that I don't know about? And they're like, nothing that we've heard of. And then, of course, at the end of conference, it was like I was just chum in the water and the sharks descended on me. And they said, Davis, we got a problem. Graduation's coming up in 6 weeks. We don't have a venue. The second years didn't do their job. We got to fix this now. So what do you do in that moment? You know, our initial impulse, it's an emotional trigger, like, get me out of here. Like, I don't want to be chum in the water. I'm going to kind of like fight my way out or fight my way back to the surface. At the end of the day, the issue, we resolved it, but it took a little bit of time. Take that step back. Let us look into this. We'll get back to you shortly. And we came up with a great plan. It was a wonderful graduation. So at the end of the day, whatever those emotional triggers are, make sure that you're reflecting. Point number 9, reasonable, transparent, consistent, always wins the day. One of the key things that you'll see here with consistency, this is such a helpful answer. We can only do for one as we would be able to do for X, because you'll get a lot of requests for one-offs. But at the end of the day, if you're making a one-off for one, you better be willing to make that one-off for 29 others. There's occasional rare 2 standard deviation from the mean circumstances. But at the end of the day, this is such a powerful statement. We can't do that. Because if we made that change, if we allowed that rotation, if we made this one exception on a weekend shift, I have to look 29 other individuals in the eye and let them know that they're getting a fair deal as well. And if I do that, they're no longer getting a fair deal. Know your policies and procedures. Make sure that you're abiding to them. This is just a picture after a decade in residency leadership. I can tell you I had no gray hair when I started, but I think there was a lot of confounding variables in there, And it brings us to our end here, fostering resiliency. The healthier the leader, the sturdier the oars. The sturdier the oars, the stronger the ship. The healthy leader, practice what you preach. Be the boss that you'd want to have. Also be the leader that you would want to have as your leader in terms of setting a good example for well-being and resiliency. I'm always hesitant when I send those 3 a.m. emails. I'm up at 3 a.m. a fair amount of time. I try to do that reply and send at 8 a.m. Most email systems, Boomerang, whatever the case. I think Gmail has it now. Send things a little bit later because I think it's helpful for those that you work with to feel that it's recognized that working 24 hours a day is not a great answer. We have to keep ourselves well. Resiliency is very important. So let's draw some conclusions here. The well-balanced leader, IQ. Everyone here, exceptionally bright and talented individuals. It's taken so much work and so much grit and so much dedication to get to where you are today and what you have achieved. The other Qs include EQ, sharpening your inner EQ, owning your mistakes, embracing that feedback, and your VQ, ventilation perfusion, very important, well-being. Whether it's exercising, I'm a big swimmer, I'm a big walker, I've started doing yoga during the pandemic, whatever those things that keep you healthy and balanced, make sure you keep on doing them during your chief year. And it really forms this triad. And the triad doesn't work and gets off balance when any one of these parameters are off balance. So let's round it out right at the top of the hour here with our top 10. Number 1, support those who you empower, embrace and march into those difficult conversations, place yourself in others' shoes often, put an email aside for 8 hours, sleep on it overnight, keep it as a draft, send it in the morning, read it again before you send it. The treachery of those e-communications, actively managing change. Change is not an email, change is a process. Make people be part of those solutions. Again, problem identifiers to problem solvers. Learning to listen, beware those holidays, step back from those tags. If you feel that visceral sensation in your chest when something comes your way, take a step back. We know our patterns, but make sure that you're thinking your way through the process. What is best for the group here? And always be reasonable, transparent, consistent, foster resiliency, and ultimately be the boss that you would want to have. I'll go ahead and conclude there. Matt, Carolyn, thank you so much for the opportunity. I'm happy to take any questions that come up.
So you can either unmute yourself or you can put your questions in the chat. It's not often that you get to, directly ask questions of a chair. So please take advantage of this opportunity. Plus he's super smart. I always learn something every year with this particular lecture.
You're too kind. Thank you, Carolyn. Thanks so much, everyone, for your time. You really enjoy the day today. Soak it all in. It's really great stuff. But don't let the education and learning end here with this forum. This is just a springboard to learn and consume more. That'd be my advice.
Awesome. John, always a pleasure. Learned a ton. Oh, there's a question coming in. How do you balance communication with your program leadership? Can you talk a little bit about the challenges there you've experienced?
Yeah, and it's just what you alluded to, and Matt, earlier, it's just that middle manager role. I am always of the mindset that being, transparent and, responsive is very important. There are certain things that you'll be privy to as a chief that you need to hold within the chiefs. But if it seems like it's going to be an issue that will get out of hand or has the potential, program leaders always appreciate the heads up. The last thing they want is kind of get that bomb from the chief medical officer, from another program director when they haven't been apprised of something. And this is something that I think is helpful clinically as well. We had a circumstance not too long ago when I was working clinically where a young patient had a cardiac arrest and died. Do we see young patients that have cardiac arrests and die in the emergency department? Sure, but not very frequently. And it was sort of, circumstances at home in terms of what happened. And, at the end of the day, this was kind of like a risky case. We felt that we did everything. We used ECMO, we did other things. At the end of the day, though, I wanted my chair to know just up front that, I'm telling you this as my chair, as my clinical chair, because I want to give you the heads up in case you get any spoken information. I want you to have the whole picture of why we ECMO and why we did these other things. The same thing with administrative things. If it's something that you can see others reaching out to your program director or your program leaders, make sure that they're hearing it first from you and not learning about things that are happening with the chiefs or the program from others. And I think that's always a good barometer of when to share things.
Yeah, I think that's a great reflection. Proactivity, right? I think if you can get in front of a message as opposed to reacting to it, it's always a way better place to be as a chief than waiting for something to bubble up. So that's great advice. So perfect. Well, I think that will do it for this session. Thank you again. Lots of love and praise for you in the chat, Dr. Davis. Your experience and leadership is always well valued here. So as we take maybe about a 5-minute stretch break, we're going to come back at 3:05 Eastern, 2:05 Central, or excuse me, 2:10 Central for Dr. Betham's chat. I'm just going to throw a question up on the screen. What's one way that you're going to lead differently as a chief because of this session? So let's lock in a little bit of that learning that we had done today over the course of this last 45 minutes, and just throw in the chat when you get a chance. If you need to get up and stretch, do a little like sun salutation, go for, a little caffeine, whatever your poison, go for it for the next 5 minutes, and we'll get started here at 10 after. Hi, Brittany.
Hello.
How are you?
Hold on, I was good. I was just scrolling through the participants list, seeing who's out there.
Awesome. Here, I'll give you, you should be able to share in just a second. I'll just leave this up for one more minute and we'll give you a chance to get all your slides loaded here in a minute or two.
Okay, sounds good.
How's Michigan? How's life in Michigan? Surging less?
Surging less. We look a little less purple on the New York Times COVID graph, so we're all feeling pretty good about that. There are a lot of good memes that came out of that.
Like,
What's that?
I haven't figured out, because Michigan was always like seemingly challenged. Like, was there something about the state, or did anyone figure out why?
We had a pretty high number of the UK variant. I think we were like the second highest in the US. So I think that kind of spread through. And I have this theory, although it's totally unfounded, that because our lockdown was one of the most robust earlier, that we just had many more people who still had yet to be infected, but I don't know. I'm not sure. It was our personal shame for a while.
Yeah, it was a concern. I mean, it was scary, I'm sure, for you guys. Like,
And it was literally just us. And I kept thinking like, okay, well, the rest of the country will look like this in 2 weeks. And if you look at it, it's not happening anywhere else. It was just Michigan.
that was what people kept talking about, because obviously, like, we're, I mean, northeast, but northwest, they kept saying like, oh, be careful, it's coming towards Toledo, like it's gonna cross. But like the boundary between the states stayed pretty clear. It was amazing.
Yeah. It's really not clear to me exactly what we were doing, but I'm happy that things are toning down a little bit. And
Yeah.
I worked as the doc at our Ford Field vaccination site the other day, and that was awesome. It was like a nice, after a full year of just pandemic and watching people do whatever they want on the news, like seeing people, like, 5,000 people come in and get vaccinated was like good for the soul for sure.
Oh, I'm sure. Oh my gosh, that must be
Yeah, it was nice. All right, do you want me to
You can go ahead and take over and share, and we'll get started here in another minute or two.
all right.
As the scheduling guru, did you actually enjoy this, or do you just have a natural talent for it in your brain, Beebs?
Oh, I love it. It's this is one of my favorite things to do. I think it's because it's kind of like a puzzle. There's a little bit of math to it. So whenever we run into an issue with the schedule, the problem solving is one of my favorite things to do. My former co-chiefs think I'm very weird because I still enjoy this and spend a lot of time thinking about it.
No, I get it. I feel like every chief class has that person that just loves the Sudoku that is the schedule. Dina was ours.
Yes.
She just, I mean, like, anytime I was like, I just can't get this person off a weekend. Like, she'd take 5 minutes and be like, here you go. And I was like, what? I spent 3 hours trying to do that.
Yeah, that's definitely me for sure. Yep.
Do you do
so
this?
I do. I help our primary scheduler who's been doing it for about 30 years because we transitioned to shift admin a couple years ago. And so I help her make the schedule. And we are trialing it for the resident group. We'll see how that goes. That's even a little bit more challenging because they've been on a template schedule for a long time, like a strict circadian pattern.
Oh.
So there's a lot of just kind of momentum with that type of schedule, a lot of comfort with it. So trying to meet a middle ground is kind of what we're working on. My Henry Ford residents on the call will know exactly what I'm talking about.
Changing schedule. That is a Band-Aid. That is an amazing thing to rip off for a chief class. Good for them. I applaud that.
It took a couple.
Yeah, go ahead.
I was gonna say it took a couple of years for me to get the senior staff group on a computerized schedule. It took a couple of years of change management. So when we were talking about that in the last session, that hit home for me.
Yeah, full disclosure, I still believe that a human still can make it better, because I have that Excel file that I just adore that has conditional formatting, everything like that. But that's my own personal problems. But okay, let's start to come back, gang. It's about 3:12. So if you could remember, get your cameras on. Dr. Betham loves seeing faces to talk to rather than just black boxes with names. I have the distinct pleasure of introducing our next speaker. Dr. Brittany Betham is a dear friend of mine. We overlapped in residency by a couple years. She was a chief resident as well, and she is now at Henry Ford Healthcare System, and leading a lot of the charge behind what sounds like updating their scheduling process and managing change. There is no one better, I think, to give you guys the skinny on how to thoughtfully build a schedule, which undoubtedly is the most important role that you all have as chiefs, because it literally affects everybody's life in the program. So without further ado, Brittany, take it away.
Thank you so much for the introduction. Thank you for having me, guys. This is a super exciting time in your residency career, so congratulations. As Matt and I were talking about, hold on, let me make sure. Okay, so as Matt and I were talking about, I was a chief resident at University of Cincinnati. I was the scheduling chief. There's always one of you, as Matt was saying, that will likely be the scheduling guru who will, if not enjoy it, at least be the one who has the mind for it. But I hope that by the end of this talk, you'll all have a general sense and get a better sense of comfort with scheduling. Currently, I work at Henry Ford Hospital in Detroit. And I love scheduling, and I also transitioned our department to shift admin within the past couple of years from what we were doing, which was a paper template schedule. So I have a little bit of experience in change management and doing things using the computer. So we're going to talk a lot about scheduling today. This is my dog, Frank. I had to throw a little personal thing on there. I think he's super handsome, but I know not everyone agrees about pugs, but that's Frank for you. So I want to start out by asking you guys how you make your schedule. Feel free to just unmute for a second and hop in and tell me, is it an Excel sheet? Are you doing it by hand? Do you use Shift Admin? Do you use Amion? What are you using? Or Matt, if they throw it in the chat, can you read it to me?
Shift Admin,
Shift
QGenda, Google Sheets,
Excel, Amion, Shift Admin, Shift Admin, Shift Admin, Excel,
MedRes.
MedRes.
Oh, MedRes, okay.
By
so
hand.
There's a wide variety.
God bless you.
Yeah. So you'll see that there are many, many different ways to do this. And it's going to be one of the most important things you do. When they surveyed emergency medicine residents about what was important in their wellness, 98% of them said that their shift schedule while they were in the emergency department was very important to their wellness. This is one of the things that you'll likely be remembered for as a chief. How good were your schedules? How bad were your schedules? And you can really have an impact on the overall well-being of your entire residency through good scheduling. So I think that's one of the reasons why we need to have this talk and why it's good to kind of get into the mode of making good schedules. What we're not going to talk about are the specifics of how you use a particular type of software, because as you saw, everybody here is making their schedule a little bit differently. I will say offline, if you have issues with Shift Admin or you want to talk about the inner workings of Shift Admin, that's kind of my home base. So I'm happy to talk to anybody offline, but we're not going to get into that today. Here's what we are going to talk about. We're going to talk about best practices for preparation in making your schedule. This is really important. Measure thrice, cut once. Get all your information in line so that you're ready to make the schedule properly. You have to know the rules. We're going to go over the duty hour rules that you need to be aware of that are universal across the board. We're going to talk about kind of the theory behind scheduling. So what makes a good schedule? What makes a bad schedule? What do residents say that they want in a schedule? We're going to talk about how to check your schedule. This is really important. Taking a close look and a methodical way of checking your schedule is going to be important to set you up for success. And then we're going to talk a little bit about taking feedback gracefully in schedule creation. So if I can give you any advice, it's give yourself plenty of time. 6 weeks before you are planning to release a schedule is when you want to start thinking about that individual schedule. It's going to take you 2 to 3 weeks to gather the information you need and at least a week of in-depth schedule creation, okay? So right now where you are is the beginning of the academic year, or you're getting close to that. This is around the time you want to start thinking about this process. So you're going to gather block schedules for your residents, get important dates from residency leadership, and get general information about your rotators at this time as you prepare to kind of plan out the entire year. Then 1 month before you release the schedule, so this is kind of thinking about a residency program where you're making a month-to-month schedule and you're releasing your schedule about 2 months before the start date of that schedule. 1 month before your schedule release, you want to start collecting your schedule requests, confirm the dates of your rotating residents, and collect important dates for that particular schedule. And then about 2 to 3 weeks before you plan to release the schedule is when you want to start making it. So let's talk a little bit more about what you need to be doing now. You want to start gathering information about your rotators. So you want to find out who their residency administrators or coordinators are, introduce yourself, give your contact information, find out who is coming when and what their scheduling expectations are. So for example, if you have internal medicine residents rotating with you, oftentimes they'll have a clinic that they need to do on a given week. Many residency programs will put their vacation period during the EM rotation. So you just want to make sure that you know about that so you can plan ahead. You want to get the block schedule of your residents so you know who's going to be in the department and when. And also find out what shifts you'll be responsible for scheduling. So you might also be putting residents in at your pediatric shop, at one of your community shops. So find out exactly which shifts are going to be the shifts that will be on your schedule. And this is really the time to negotiate if you need to even out coverage over the course of the year. You may put together kind of an Excel spreadsheet that shows when each different rotating or residency program is sending residents to your ER and find out that you have 10 rotators in 1 month and 2 in another. That's going to put a lot of strain on your ability to create a balanced schedule. So now is really the time to reach out and say, hey, do you guys have any flexibility? Is there any way that you could send us a resident in this month instead of that month? You won't always get that ask. They won't always be able to accommodate you, but you never know unless you try. So this is really the time to do that. The other important thing about schedule creation is that you have to communicate your schedule to other people once it's created. So you need to find out who needs your schedule. So that could be off-service administrators. So the other programs that send residents to your department are going to need to have access to that schedule. Administrators at your other clinical sites, so at your community shop, at your pediatric shop, your residency leadership, and of course, your residents. And then now is a good time to start thinking about a timeline for when you're going to start working on and release each schedule so that you can kind of stay up to date as the year goes on. So let's talk about each preparation before each individual schedule. So as you're getting ready to make the next month's schedule, you want to reconfirm which rotators are coming and what their scheduling limitations are. So instead of knowing, okay, we're going to get 3 internal medicine residents this month, you want to find out their names, get their contact information, which day do you have clinic, do you have vacation during this period, find out what they're coming from and going to so that you know kind of what their edges look like. Make sure you give them your contact information as well and get theirs, because if they don't show up for a shift or there's a scheduling error, you want to be able to get a hold of them really quickly. Then you want to gather the information you need to make your schedule. So find out which of your residents are going to be in the ER for this block. Find out if anybody's on vacation and when. And really important, same as for your rotating residents, for your residents, you want to know what are they coming from and what are they going to. So if they come from the MICU, they could have been on a 32-hour call. If they're coming from ortho and they're working nights, night call on ortho, you want to know that because that will determine what is the first shift they can work on your schedule or whether or not they might need a day off or a break. So really important to know what they're coming from and what they're going to. If you are using schedule requests, and I'm going to talk about why it's a good idea to do that, you want to gather that information. And then also make sure you talk to residency leadership about important dates. Is there a leadership forum that's happening? Is there a social for one particular class? You want to know about that stuff ahead of time so you can help schedule around it. This is an example of the kind of spreadsheet that I set up when I was getting ready to make a schedule. I have a couple of these in here. So you can see that I marked down what the resident was coming from, which dates they were going to be in the ER, and if they were going to be on vacation or if they had any elective time, what they were going to, and then what requests they had. And then I had some notes in there about important dates. This is another example. I kind of split the month up into 2 halves because in our residency program, we had sort of a 2-week block within the 1 month block schedule. But it's the same thing. Collate all of your information into one place so that you can use it as a reference, both when you're making your schedule and when you're checking it. I found this to be super helpful. All right, so let's talk about duty hours. So we're going to get into a little bit about the theory of scheduling in a second, but this is the sort of bare minimum. You must honor these, otherwise your program is going to be in a major violation. No shift can be longer than 12 hours. You can't work doubles. Everybody's shift has to be no more than 12 hours. And then time off after the shift must be equal to the amount of time you worked on the shift and at least 8 hours. So if you're a program that has 9-hour shifts or 10-hour shifts, the amount of time that a resident has off afterwards has to be equal to the amount of time they just worked in the emergency department. You can have no more than 60 hours of patient care in the ED per week, and this is not an average. So if you were to add up at any point in 1 week the number of hours your residents spend in the department, it can't be more than 60. And you can't have any more than 72 hours of patient care per week. And I think that talk gets into a little bit about time spent afterwards and documentation, or time spent over on the shift finishing up work. They can't be more than 72 hours of patient care in total. That's also true for internal medicine residents who have clinics. You just want to kind of keep that in mind. Clinic counts as patient care. You have to have a minimum of 1 24-hour period off every 7 days. So nobody can work 7 days in a row. There always has to be 24 hours off in there somewhere. And that's not averaged over 4 weeks. And then it's important to note that if you allow moonlighting, moonlighting does count towards duty hours and can't interfere with your main educational responsibilities. So if you are responsible for approving moonlighting for your residents, you need to make sure that as you're looking at those shifts that residents are asking to pick up, make sure they don't violate any of these other rules. And then every resident needs to have 4 full days off of clinical and educational responsibilities per month. So make sure you know these, make sure that every schedule you make is in compliance with these rules, because these are really hard stops. So let's talk a little bit about making the schedule. So I'm going to go into some best practices for shift scheduling, but I want to caveat it by saying that if your program has a very specific way that they've been making their schedule for a long time, you want to talk to residency leadership before you go in and try to make any major changes. But we'll talk a little bit about schedule theory and what a good schedule looks like. So keep the number and type of shift relatively even across residents in the same class. Every residency class has a shift counter. You know who you are, or you will find out who in your class is the shift counter. It's okay, that's natural. There's always going to be somebody. One way that you can mitigate this is by setting up your schedule in such a way that every resident has a similar breakdown of shifts. So if you have a geographic difference in your department, maybe there's like at Henry Ford, for example, we have a high acuity section and a low acuity section. You want to make sure that one resident doesn't spend their whole month in the high acuity section and another resident doesn't spend their whole month in the low acuity section. As far as peds and community shifts go, you want to make sure those are evenly interspersed. Using circadian patterns is super important in your shift progression, and we'll talk a little bit more about what circadian rhythms are in a minute. It is generally considered to be a best practice to allow residents to make some schedule requests. Having some control over your schedule is one of the things that residents value a lot. Giving one golden weekend, meaning a full weekend off of clinical responsibilities, is something that residents value and can be good for wellness. And at least one longer block of 2 to 3 consecutive days is generally considered to be desirable if possible. All right, so I'm going to nerd out a little bit on sleep science just for a second. So humans actually have a 25-hour circadian rhythm. So what this means is that if we were to put you in a cave where you had no ability to sense the outside world, you would go to sleep 1 hour later every single day. And so as a result, humans generally do a better job of pushing back their sleep and staying awake a little bit longer and starting a little bit later the next day than they do moving forward. This is one of the reasons why a circadian shift progression feels more natural and more healthy for us. So what it means is that as you work through a block of shifts, your next shift will start later the next day than your shift did the day before. So for example, here we have a person working a 7 a.m. start time day shift, moving into an afternoon swing shift, moving to a midnight. It doesn't have to be that it progresses forward every single day, but it can't progress backwards. So you don't want to have someone start at 8 a.m. one day and then start at 7 a.m. the next day, or start at 3 p.m. one day and start at 7 a.m. the next day, because that doesn't feel natural, and that's generally considered to be detrimental to both wellness and health. But there are some residency programs that do kind of a strict circadian progression pattern. And what they found is when you ask residents what they want, they say they actually rate it higher to have the ability to take a day off when they want it, and to have a full weekend away than to do a clockwise shift rotation. So there's a balance between the two. You want a circadian pattern in what you do, but you also want to maintain some flexibility to allow residents to have some time off on a weekend and to request a specific day. So if you're going to offer schedule requests, here are some best practices. Set a firm closing date. So you want to tell residents you have 1 week to put in your requests, and at the end of your closing period, requests that come afterwards don't get honored. This is for your sanity. It's kind of for the equity within the department. Let people know, give them a reminder, but hold firm to your closing date. A couple different ways you can approach this. We used a Google form for requests. We liked that because it allowed us to kind of triage requests a little bit if we had a few and we weren't able to honor them, which was rare, but it was helpful to kind of get it in a more personal way. Shift admin and other types of scheduling software will also let you put in your schedule requests individually. And so that can save you some time. So you have a couple different options there. You want to distinguish between personal and academic requests. I think that's helpful to know, hey, I want this weekend off because it's my anniversary, or I'm giving a lecture, or I'm teaching at an EMS department and I need this time off. That allows residents to have a little bit more flexibility in their requests. And then we always reminded our colleagues, a request for a day off is really a request to have someone else work in your place. So use it wisely. We wanted to create an ethos around, we understand that people have lives and they want to take time off, but just remember that anytime you ask us for a day off, you're asking for somebody else to work in your place. So keep that in mind as you're making requests. And we found generally that people were pretty good about it. All right, so now we're going to get into the sticky wicket. So we're going to talk about night shifts. First, I'm going to talk to you about what the ACEP says are best practices for night shifts, and then we're going to talk about what works for residency. So generally speaking, the gold standard for covering nights is to have dedicated night physicians. So somebody that only works nights. This is partially because it's healthier for everyone, and it's also specifically healthier for somebody who's doing shift work. So if you're only working night shifts and then you can get some anchor sleep in between, that's the gold standard. The other option is to have isolated, infrequent nights. So what we're talking about is one night shift a month, not a block of nights, just one night, so that you're not really switching into a nocturnal rhythm at any point. This is a little bit less desirable, but a good option is to have long or several week blocks of nights. Some residency programs actually do this. They'll do a 2-week block of just night shifts or a 1-month block of night shifts. But that can lead to social isolation. So it has some social downstream effects that are negative. The worst approach actually is to do what most residency programs do, which is to give you a block of 3 to 6 night shifts in a row. And I think the reason why we do that is for a few reasons. One, residents have an overall high number of shifts, right? You're here to learn, you're working a lot. And among those, you have a pretty high night shift burden. Most residency programs do between 4 and 10 night shifts per resident per month. So you have a lot of nights that you need to fit in there. And like I said, long stretches of night shifts can result in social isolation. Being a resident in and of itself can be socially isolating. You're working a lot. Your built-in friend group, your co-residents are often working when you're not working. And so adding a block of nights into that can actually deepen social isolation, which is one of the reasons why it isn't done very commonly. Residents really prefer a strategy that limits the number of times they have to make a circadian adjustment and avoids prolonged periods of social isolation. So this is the reason why many of you may find yourselves in a residency program where you're doing a block of 3 to 6 night shifts. And actually, when they survey residents, even though we know that the best practice guidelines for your physiology are to do either only nights or just one night at a time, residents typically prefer this method of 3 to 6 nights in 1 or 2 blocks per month. So isolated night shifts, impractical for you, probably. Too many night to day switches. Long blocks of nights are isolating. 1 or 2 shorter blocks of nights are preferred by residents, but probably physiologically detrimental. Regardless of what you decide to do in your residency program, the most important thing is to ensure adequate time to switch back to days And generally that's more than 24 hours. So you want to avoid wherever possible having a resident come off shift at 7 a.m. and then go back to a day shift the next day. So no matter how you do your night shifts, make sure you're giving enough time for that transition. All right. So the next thing we're going to talk about, you've made your schedule, you've taken your circadian patterns into account, you have gotten the whole thing filled out, and now you're ready to check it and make sure that it's accurate. Your first step is going to be to look for critical errors. So make sure there's a doctor in every shift that you're supposed to be scheduling. You don't want any holes. That no doctor is in a shift she's not allowed to work. So you don't want to have a junior in a senior only role. You don't want to have a senior in an intern role. Make sure that everybody is scheduled correctly. You want to check for duty hour violations. Any duty hour violation must be fixed. You cannot publish a schedule with a duty hour violation. Make sure that no doctor is double assigned. So if you have a resident that's supposed to be in the SICU and you have them work the ED shifts, that's going to be a problem. So be very sure that everybody that's in the department is supposed to be there that month. And then mind the edges. This is the thing that will drive you absolutely crazy. You don't want to schedule a resident for a day shift on the first day of the block when they're finishing their last ortho night shift the night before, because they won't be able to work. So be very clear about what someone is coming from and make sure that you don't schedule them into a violation. Best practice is to give a day off after off-service rotations in most cases. So the first day of your block, that resident should be off. If you can't do that, make sure that whatever you put them in aligns with their prior schedule. So if they came off nights, you want to start them on nights, that kind of thing. Your next step is going to be to check to make sure your educational objectives are met. So make sure that different types of shifts are balanced. So if you have pediatric shifts, make sure that no resident goes the entire month without a ped shift. You want to make sure that everybody is kind of balanced across your different types of clinical sites. Balance between low and high acuity or community and academic. And then also make sure the workload is evenly distributed. It's not going to be possible all the time for every resident to have the exact same number of shifts, but you want to avoid situations in which one resident has 3 more shifts than everybody else, okay? Because that's the type of thing that is both not good for wellness and is also going to be a contentious point for that resident. And then finally, think about wellness. So what I would do is when I'm checking a schedule, I look at every single person's schedule individually, and I imagine myself working that schedule myself. And I think, where does this hurt for me? What in this schedule bothers me? What would I prefer to have different? And then make adjustments where you see wellness issues. So if you can make a trade that will make that schedule feel better, you should try to do that. You may not be able to make a trade, but everywhere that you can to improve shift balance or circadian patterns, or to get a schedule request that wasn't originally honored, that's time well spent. Let's talk a little bit about what are the major pain points in scheduling. So absolute workload or imbalances in workload are going to be huge. So remember I talked about that resident who counts shifts. That person is going to be in your ear a lot, and you want to make sure that to the best of your ability, you keep the schedules even across residency classes so that you minimize that pain point. Shift distribution, so making sure that people have the same type of shift. Most of us will have the experience of having a particular shift in our department that's maybe a little bit of a more chill shift, and then a particular shift that's kind of a butt kicking. You want to make sure that you don't put a resident in the butt kicking shift for the whole month. Give them a mixture of shifts. Denied schedule requests are going to be a pain point for you. You may not be able to honor every schedule request, but to the extent that you can get people 1 or 2 of their schedule requests most months, it's going to be helpful. These are a couple of important things: the post-transition night day off and the grand rounds day off. Ideally, you want to minimize the number that a resident has. So for example, if one resident, all of their days off occur on your conference day, that person isn't really getting a day off. So you want to think about where their days off fall and make sure that they're not coming to conference every time they don't have to work. And then the other component to think about is those day to night transitions. You want to make sure that you kind of avoid that situation, like I mentioned before, where a resident is coming off work at 7 a.m. and going to work at 7 p.m. the next day. Even though that technically meets the 24 hours off requirement required in your duty hours, we all know that that isn't really a day off. You're spending most of that day sleeping. And so you really don't want to avoid a situation in which a resident's day off is truly just that post overnight day. Weekends are key. Giving residents a weekend off is going to be huge just to help align them with the social schedules of people who are not doctors. And then holidays as well. Making sure that you have an equitable system for accounting for holidays is going to be important. And then another thing to think about are long strings back to back with only one day off in between. Technically, you can schedule a resident for 6 days on, 1 day off, 6 days on. But we all know that working 12 shifts in 13 days is extremely fatiguing. So you want to take a look at that. If you have a resident with a really long stretch, and then you only give them 1 day off before their next long stretch, try to figure out how to make that gap a little bit wider. Okay, so now we're going to do a little bit of audience participation, hopefully. So take a look at this schedule. This schedule has some problems. And shout out to me, as you're looking through this, imagine you're living this schedule. What stands out to you as something that might be a pain point here?
Two separate instances of night shifts.
Okay.
The day to the night, Saturday, Sunday.
Yes, or the Tuesday, Thursday transition where they come off a night shift and then they go immediately back to a day shift. Yep.
Only 4 days total.
Yes, very good. Yeah. So this person is working a lot of swing shifts, right? So really good. You guys pointed out all of the things here that I sort of set up that are problems. So having that swing today isn't technically anti-circadian, but if you have a lot of those where you come off a swing shift and come on a day shift right after 1 day off, you want to keep an eye on that because that is not the most comfortable turnaround. It's doable, but it's not great. That night to day shift is the type of thing where you really want to be putting more space between those to allow for that person to readjust. And then also swing shifts are one of the most, day shifts are most aligned with other people's schedules. Swing shifts, if you're doing a lot of them, that can also result in some social isolation. So try to make sure your swing shifts are evenly distributed and you really don't want somebody working only swings in a particular schedule.
Especially because those swing shifts can often be the butt kicking shifts that you mentioned earlier, because that's when big peaks or arrival are. So there's not going to be any sitting around and relaxing like maybe the tail end of the overnight shift or the beginning of the day shift.
Yeah, that's a great point. Yep. So swings are their own kind of, we tend to ignore them, but they can actually be kind of a bugaboo for your schedule. So just keep an eye on that. All right. And then check it twice. You will get apathetic looking at the schedule. You're going to look at a schedule you made for 5 or 6 hours, and you might see something where you think, man, that doesn't look like a nice schedule to live, but I'm tired of editing this schedule. If you feel that way, just walk away from it. Walk away from it, come back to it the next day when you're fresh, because you really want to give your full attention and kind of your full energy to schedule creation if you can. Have at least one co-chief double check your work. So we always had a policy, once we had checked our full schedule, we would assign one residency class to each of our co-chiefs and have them look through. Because oftentimes your co-chief will pick up on something that you didn't notice the first time around. And help you avoid some major errors. And then everyone has an opinion and it's okay. So you will get feedback from your co-residents about your schedules. You might overhear them talking about it in the clinical arena. They might say it to your face. It's only natural, right? The schedule is one of the things that impacts our lives the most directly, and can also be the thing that people feel is most negatively affecting their wellness. It's going to be normal for people to come up to you and be like, man, my schedule totally sucked this month. Try as best you can not to take it personally. It's only natural for those folks to be thinking only about their schedule. They don't know all of the work you put in. They don't know what trade-offs you might have had to make to get them the schedule that they do have and how much worse it could have been. And they won't know that unless they make a schedule. If you mess up, own up to it, okay? That's the thing I want you to take away. If you do something wrong, if you violated duty hours for someone, if you really made an error, own up to it and help that resident try to fix it. If a resident comes to you with a late schedule request, like they're kind of on their own. But if you did something that messed up their schedule, you should in good faith try to help them fix that problem. And if you notice a pattern, if you're starting to get the same feedback over and over again from a group of residents, it might be time to go back and look at the schedule again and see if you have a systematic issue that needs to be fixed. So try to take it in stride. Try not to take it personally, and just know that it's normal, and you'll be okay. So in summary, prepare carefully, measure thrice, cut once. Definitely do not violate duty hours. Make sure that however you make your schedule, the shifts proceed in a circadian way, whether that's with a template or with an algorithm. Check and double check your work and keep resident wellness kind of at the center of what you do, and you'll do great. So let me stop sharing. So we ended a little bit early. I am happy to take questions from you guys. I'm looking through the chat here too.
That was awesome. I always learn something from this and take notes every year. You know, to get the question started, can you talk to, because I think one of the challenges I've seen consistently with chiefs is that feedback that you get about your schedule, because it's not always given in the most professional or even thoughtful way, right? As I think you already mentioned, people don't always come to you as the chief to tell you the schedule sucks. They're just looking to you as their friend. Little do they realize you were the one that put all the work in. So can you talk to me a little bit about like some strategies you use to, you know, keep your ego from being too bruised or, you know, responding, you know, to some of these complaints?
Yeah, I think honestly, a lot of times people just want to be heard. So I'll usually employ an active listening approach because honestly, like I help to make the staff schedule now. So I still deal with this from time to time. Occasionally I'll delve a little bit deeper into what the issue is. So I'll ask a couple of questions like, tell me like, what did you originally request? What did you need? You know, what did you need the time for? I try not to get defensive. So I try not to say like, oh, well, we had to do that because of this, because that doesn't really resonate with people. If it's really an issue, then I'll often say like, hey, let me look into that and I'll get back to you. And that's all you really need to do. Make sure they feel heard, get the information you might need about that schedule issue. If they're just venting, you can say, hey, I'm sorry, you know, this, we do the best what we can with every schedule. But sometimes we're not able to honor requests. And, you know, I'm sorry that happened. If you need to vent about somebody venting to you, your co-chiefs are a pretty safe space. So if we ever got some feedback that like really bothered us, I would try to just like hold in my anger at that moment and then kind of commiserate with my co-chiefs later.
Awesome. I'm looking at the chat and it looks like the next question is, how do you deal with the resident who constantly complains about the schedule no matter what? They could have like the slackest, beautifulest schedule and still doesn't meet their expectations. How do you manage that with consistent monthly complaints with the same person?
That's a good question. I mean, kind of piggybacking off of what was said in the last session, having a conversation about it one-on-one is probably the way to start. I would schedule some time with that person and say, you know, let's talk about this. We're getting a lot of feedback from you about your schedule. Can you talk to me a little bit about what's going on? Our kind of ethos as a chief resident class was seek first to understand. There might be something going on in that resident's life that you don't realize is causing them some strife. So it's good to kind of just figure out, where are they coming from? Do they have a childcare responsibility that they're struggling with? Are they just struggling in general? Try to get some information from that person about what's going on with them. If it's truly just that they're, for lack of a better way to put it, selfish and they only think about their schedule, it's probably a good time to set some expectations with them and just say, look, you know, our goal is to make the best schedule possible. We can't always get you all of the things that you need every month. And we recognize that and we're sorry. We'll do the best we can, but we're going to need you to kind of keep this feedback to duty hour violations or specific problems, and just set expectations with that person. If you find that doesn't work, it might be time to involve residency leadership, at least to the extent that it becomes disruptive to your work.
That's some good advice. I think, you know, another question that seems to be popping up frequently is, you know, it always seems that no matter, as you pointed out, there's no perfect schedule. And sometimes the squeaky wheel gets the grease. You know, that loud resident sometimes that asks for a lot, you do kind of say, well, if I can afford it, I'll make it happen for them. What happens to the resident who is the, you know, like Atlas, who just carries the world on their back every month and, you know, oh, I can cut your golden weekend down and you can go into it post overnight and come back, you know, early on the next morning, that sort of thing. Like how did you ensure that not somebody didn't always get screwed in your scheduling over the course of a year?
That's a great question. Ultimately, you have to be that person's advocate as the scheduler. One way you can do that is by keeping track of cumulative schedule requests throughout the year, not as a way to be punitive, but if you have to weigh, cutting someone's golden weekend to give somebody who has had all their schedule requests for 6 months honored, that might be the time in which you say, hey, we're not going to do that. This other person has, been coming to work, no complaints, no schedule requests. You want to make sure that you keep an eye on that. That's definitely something to be aware of, especially if you have a situation where you're not able to honor most schedule requests every month. Keeping a tally of whose have been honored and whose have not can help you to maintain that balance month to month. And then I do that now still in my scheduling. So if I am looking at a schedule for someone who never makes a request and never complains, I try to make a mental note. Let me make sure this schedule is livable and comfortable and good, because I don't want that person to get the short straw just by being, hardworking and putting their head down.
And this may seem counterintuitive to what has gotten you to this level of leadership, gang, but you should highlight your successes, right? So when you are able to get someone, whether they the squeaky wheel or not, an amazing schedule, it is well worth letting that person know, we worked really hard on this schedule for you because this is the month that you have a, big wedding, family wedding you wanted to get to or something like that. It is not, you don't have to guilt them into it, but just a single line in an email that says, we really worked hard for you, goes a really long way. I'm interested in your thoughts on that, Dr. Betham.
So we did not do a lot of success like telegraphing necessarily, because no matter how nice you make the schedule, you're still working, 20 to 24 shifts a month as a resident. So ultimately, it still, I think, felt pretty intense, regardless of how good it was. That's a good place to start for the squeaky wheel resident, the one who's coming to you with complaints all the time. You might want to set up for that meeting with a list of the things you were able to get that resident over time to kind of put that into perspective for them. As far as DOMAs, there was a question about DOMAs in the chat. We tried to limit it to 1 DOMA per month. DOMA, for those of you who don't know, is that time period where you come off the midnight at 7 a.m. and go back to the day shift. We did not make it a hard violation in shift admin, but because occasionally it was necessary. But if it did happen, we tried to make sure that no resident had more than 1 in a given month. And same for the GROMA, the Grand Rounds Day Off. There are some, I think in the residency program that we have now, the way the schedule is set up, we don't have any DOMAs at all, but that does limit your flexibility a little bit. Did I miss anything? I think that was mostly it. Yeah, managing, you will find, generally speaking, that the bulk of your classmates are not going to be in your ear all the time about the schedule. What will most likely happen is you'll overhear them complaining to each other, which honestly I found kind of hurt the most. So you just have to try to remind yourself. I mean, if you're making a good faith effort every month to make a schedule that is livable, and you're putting in the time, you're trying to keep things as even as possible. Don't kill yourself over how even it is, but try to make it as even as possible. If you're doing that, then you can really feel good, regardless of what people are saying about the schedule, that you're doing the best that you can. And ultimately, you'll just have to have faith in yourself and use your co-residents as your support in that way, because they're really the people who understand what you're going through. They're also likely to be making schedules and getting that same feedback. So as much as you can kind of support each other, I think that's key. But generally speaking, you guys are all hardworking. Your classmates are hardworking. You won't get too much grief, I don't think.
Awesome. Well, clearly by all the questions, this is an area where people are quite nervous about their future role, which is totally understandable, because as you sort of set the stage for us, literally the rest of the residency's lives are in your hands going forward. I know that sounds like hyperbole, but it's not, honestly. Their lives, their schedule are in your hands. So thank you, Dr. Betham, for a phenomenal talk. That was really helpful, set the stage for a great opportunity for schedule.
I just sent her a private message also, Matt.
Perfect, great, thank you. Just a minute here, we just need to get our host to.
No worries.
She's with us all afternoon, so she's probably taking a little stretch break too.
Can't blame her.
You could just do an interpretive dance while we're waiting.
Right? Yeah. It's going to be so nice, but also weird when we all go back to like normal conferences next year. You think we're all going to be able to sit still? Like, we can't just drag our phone to the bathroom with us and turn it on. Like, right?
So
Can't
true.
Zoom from bed like I'm laying there. Yeah.
No more yoga pants. It's gonna be a different. I mean, some people still wear yoga pants to ER conferences. That's why we love ER conferences, right?
Yeah, right. Exactly. But yeah, I feel like my residents are really going to struggle not being able to just like roll over in bed on conference and just look at that. Like, yeah, no, there is that is going to be a big change.
Yeah.
I'm more interested. I wanted to do a social experiment, but obviously no one would let me this year during recruitment and just see how many people are actually in the Zoom mullet of like, how many of you have a suit up here, but are really just wearing shorts down below? Like,
Yeah, I just have pajamas on all together, right?
yeah, right.
So I actually asked my fourth years, but before interview season started, I was like, okay, guys, if I told you to just wear workout clothes or pajamas and be comfy for interview season, would you do it? And they were like, no. And I was like, okay. So we went with like normal, but I was totally ready to be like, you know what, guys, we're on Zoom. Wear whatever you want.
Yeah,
And
right. Like, for some reason, the suit does not have the same effect on me via Zoom that it did in person. So, yeah, seriously.
Yeah.
So Dr. Tui, check out. You should be a host.
Yep, I've got it now.
Thanks, Margaret. Well, as we start to come back, gang, we have a great treat. Dr. Shannon Tui, who is the program director at University of California at Irvine, is here with us today to talk a little bit about really innovating your curriculum so it's effective and engaging. Yeah, I am going to let her take it away.
Awesome. Thank you so much, Matt. All right, guys, if you have any questions, this is very informal. Oops, let's turn that off. Hold on. Let's see, where am I? I really like the accessibility of the, there we go. That it gives the option of showing subtitles, but they're very distracting. All right, guys, so this is pretty informal, so please stop me if you have any questions. I do have the chat open. I'll try to keep an eye on it, but let me know if you have any questions. So we're going to be talking about engaging residents through curriculum innovations. And my email, I'll give you guys later. So we're all used to passive learning, right? We all went to college. This is mostly what college was. Someone sits and talks to you. But studies have shown that even an adult learner really can only pay attention for about 15 to 20 minutes before you lose them. So I'm not saying that lectures should never be done, but they tend to have a bad rap. And you definitely don't want 5 hours of lectures. Just no one is going to be engaging in that. You're not going to get what you want out of it. So what other options do we have? So we're going to be mostly talking about active learning today, which is engaging residents, keeping them involved in the actual educational content. And there's several ways to do that. So our objectives today, we want to describe the different ways to encourage active learning during didactics. You guys are going to participate in and understand the components of a team-based learning session. We're going to review some options for audience response systems. We're going to list some other options for small group learning and games, as well as resources. And then we're going to review some slide design skills and resources and some examples towards the end. Although honestly, most of that is like 100 slides that you guys can look at how they're built out and just steal them. Just when you're done, I'll make sure Matt has the link to download these slides and he can send it out to you guys. So first, I just want to kind of address some lessons learned from COVID. So when I gave this lecture last year, we were at the beginning of COVID. And so the lecture was predominantly geared towards virtual didactics because we were all starting towards that. I don't think virtual didactics are completely gone with the ending of COVID. I don't know how many of you guys are back to in-person. We're supposed to be in 2 weeks. Remains to be seen. We're in California, so we're a little slow. So hopefully some of you guys are back to in-person already. But I think there are some benefits, as Matt and I were joking about, like a lot of our residents enjoy laying in bed for conferences. I think it's a little harder to stay engaged for 4.5 hours on a computer. I know my residents miss seeing each other. So when we can, we're gonna go back to in-person. But my residents have voted to maintain a once per block virtual session. So for every 4 weeks, we'll have 1 sim, 1 virtual, and 2 in-person in our normal lecture hall. And I think that's going to be a really nice combination, which is a lot of what this lecture is. Just mix things up, and that's half of how you engage people. Don't talk at them for 5 hours, but you also can't force them to play games for 5 hours because that gets old too. So you have to change up what you're doing. So first we're going to do TBL. So I don't know how many of you guys have done TBLs before, but this one's a little silly. It's on cookies, but it's a little more fun than something in medicine. So in general, every single TBL is going to first start with an LRC, or a learner responsible content. So learner responsible content is something the learners are supposed to do prior to coming to the session. Now, this is easier with med students. With residents, you guys are busy. It's hard to do reading in advance. If any of your residencies use what's called III, which is kind of asynchronous learning that ACGME allows up to 20% of your didactics to be, if you do, you could build this into that, right? You could have someone do 30 minutes of reading at home, and that would count as the III, and then they're going to come in for this. So residents can actually get credit for this. ACGME allows for that. So something to keep in mind, but actually ensuring compliance is different. And I realize it's kind of difficult with busy residents, especially people in MICU, SICU, some of the harder rotations. It's hard to find the time. I'm not gonna make you read this article here, but the link's at the bottom. It's just an article about baking cookies. So TBLs, for traditional TBL, the next step is an IRAT. This is an individual readiness assurance test. So in an in-person setting, it would look something like this. So it's just a multiple choice test. And everyone would sit down and answer their own questions based on their reading and what they know on the topic. Now, when we switched to virtual, it was a little bit different. So if you guys go to this link, I'll pull it up here as well. You can use Google Forms to make something very similar. So Google Forms is free, and Google Forms has a lot of options. And so making a multiple choice test, very easy. So you could do an IRAT this way instead. And so you could have the residents on their virtual platform or on their computers in the lecture hall, click through everything and select their answers. Now you've got a couple of options. One, you can get a report out and see which questions they struggled with most. You could actually have people put their names in and see if anyone's really struggling on it, but you would have everyone submit their answers. The next would be a GRAT, which is a group readiness assurance test. And so now in general, this is the exact same multiple choice test as the IRAT, but you're gonna put people in small groups. And so in person, put them in small groups, have them sit together. And then this type of session is, this type of form is called IFAT, where it's got the scratch off stickers, which can be bought on Amazon, just search scratch off stickers and cut down to size. And so in each small group, everyone would discuss their answers, see where they differ, come up with a consensus, and scratch off the answer they think it is. And they get immediate feedback on whether they're right or not, because the right answers have a star and the wrong answers just have the letter that it would be. So the really nice thing about TBLs is if you have a larger residency, a single instructor can run the entire room with this, because I don't need to be at every small group while they're working through it if they have any questions or if they don't know what the right answer is. This form gives them the right answer. So I can run, when we did this in person 2 years ago for SAEM, I ran a group of what, I think they had 120 chiefs there, and you guys all ran through this together. So same thing for virtual settings, or if you just want to be more techie, you can do something similar with Google Forms, where each question ends up being, the way you build it out is you go to sections based on their answers. And you can do the same thing where they get immediate feedback. So flour helps the cookie hold its shape and changes the consistency. Which of the following happens if you add more flour? I think they're going to be crisper and thicker. And it tells me that's correct. So I ran out of baking soda. This one was out in a cookie, that is, and I'm gonna pick the wrong one this time. And it's gonna tell me wrong, try again. And it's gonna bounce me back to that question and force me to do it. Now you can also have explanations on these. So Google Forms gives you a lot of options for that. And the next part of a TBL would be a group application exercise. And again, usually I would run you guys through this, but it's a little hard because putting, there's a lot of you guys, it's like 100 of you into small groups would be a little tricky. We could do breakout rooms with Zoom, but I think it would take too long. So the group application exercise is typically going to be something where you work with your group to apply what you just learned. So in medicine, it's typically going to be cases, right? So maybe it's an asthma lecture, maybe it's an asthma TBL. And so it's a bunch of cases about like a pediatric patient who comes in with asthma. What's your differential? What's your next best steps? What diagnostic studies would you order? And so those would be the kind of questions. And again, this one's a little silly because it's cookies, but it's a recipe, and then it discusses different ways you can change the recipe. And same thing, if you were just still doing a virtual format or you wanted to do something a little more techie, you could do that exact same thing here. And again, the nice thing is I can collect more data this way. So if you're trying to get some information about where your residents are struggling, doing it this way, you can see exactly what every group answered and see where there were gaps. Any questions so far about the TBLs? All right, so typically a classic TBL is the learner responsible content, the individual readiness assurance test, group readiness assurance test, and then the group application exercise. Now that said, there are things called modified TBLs, which breaks down different pieces of this. So you could ignore the learner responsible content because you know most of your residents aren't gonna have time to read it, and you could just go straight into the IRAT, GRAT, and GAE. Or you could do something in a larger group setting. So this is a red eye TBL that we have, where this goes up on the board. And so this is just a bunch of different pictures of various red eyes, right? And the residents have a list of questions, or descriptions. So this one's closure or narrowing of the anterior chamber angle, causing elevated intraocular pressure and eventual optic nerve damage. And they have to pick which picture it is. So in this case, it's H. It's the one that is a little bit cloudy, fixed in mid, right down here. And the other pictures don't match that. So basically they go through and match all these descriptions and diagnoses with the images. So that's just a modified way to do a TBL. Very similar, because you're gonna still have an IRAT and a group application exercise, but, and you can run it similarly, but you don't necessarily have to have, it doesn't have to be a multiple choice question. It doesn't have to be, there could be images involved, there could be cases involved. The next thing I want to talk to you guys about is an audience response systems. So this was easy, right, when we were on Zoom, because there was chat. And so for chat, I'm actually trying to figure out what program I can use for my residents for in-person, because I want a little chat box at the bottom of all my lectures, because it was great, right? Residents were talking about things, they were engaging, they were making jokes, they were asking questions probably more than they would be, because there was a very easy, low-risk way to do so. So I'm trying to figure out how I can implement that. I haven't found a program yet to do it other than a giant group chat, which I don't want to do. So as soon as I do, I will let you guys know. But audience response systems are another way to sort of incorporate that more formally. So there's a bunch of different options, and I'll give you guys a slide that kind of compares and contrasts them. These are some of the bigger ones. So Poll Everywhere, Slido, Socrative, get Kahoot, and then Mentimeter. So the two we're going to talk about show today are Poll Everywhere and Kahoot. So there's a bunch of different ways you can use this. So you can solidify knowledge, you can check understanding. So how comfortable are you with this topic? Does anyone have any questions on this topic? You could ask them questions. You could just ask them questions and see how many people are right to make sure there's no gaps. Team competitions, you can actually break people up into groups and have like your first and your second and your third years all against each other. And it can be used in place of hand raising, right? If you've got a bunch of interns that maybe are a little bit nervous about asking stupid questions, using this gives people an option to be anonymous and ask things and fill in gaps that they don't know. So this one I do want you guys to do. So you can either, if you have your phone with you, you can either do via text, and you can text UCIEM to 22333, or I assume a lot of you are on your computers. So via the web, you can just go to pollev.com/UCIEM. And I'll give you guys a minute to do that. And so once you get in there, you're gonna have the option to answer my questions. And I'm just gonna show you guys a couple of different ways to use this. And again, they're all gonna be silly and non-medical related for the most part. But so here's one. So this could actually just be a multiple choice question instead, but I'm gonna ask you guys what your favorite ice cream flavor is. So you can either text the answer A, B, C, D, E if you're using your phone, or if you have a computer or a device that you're on the website, it'll give you the options. Mint chocolate chip, it always wins. Oh, chocolate's taking the lead. Wow, I haven't seen that in a long time. Nobody likes vanilla, poor vanilla. They are unloved. All right, so that's one way you guys can use it. And so if I was asking a multiple choice question, if everyone got it wrong, now I would know I need to kind of fill some gaps and explain something a little bit better. So next way you can do it is just freeform. So what's your favorite pizza topping? So you guys can type in whatever you want. So, or you can text it to, once you've texted UCIEM to 22333, you can just text whatever. Hamburger, nice, pepperoni, all good choices, all toppings. And so this is a good way that you could just be like, does anyone have any questions? And let people fill in the gap. Or if you wanted to do, you were doing an M&M and you wanted to ask everyone what their differential diagnosis is. This would be a really nice way to get everyone involved without them necessarily yelling out in case they aren't prone to do so. So again, it kind of depends how active your residents are in general and how vocal. Yes, so sometimes this could be a problem if people say random unrelated things. I find it's generally not an issue with residents. Even my med students generally behave. It was actually faculty who have been the worst on this ever. It was the first time we did the cookie TBL. And so for the rest of the time, every time it was freeform, they just kept asking us where the cookies were because we talked to them about cookies for an hour and they wanted to know where the cookies were. So if faculty are the only people I've ever had be disruptive on this, if that makes you feel any better. But yes, that can be a problem. Hawaiian, oh, I mean, some people do love Hawaiian. All right. So which of these patients has hypothyroidism? I had cleared this before. A bunch of you guys must have seen this ahead. So most of you guys answered correctly. It is the person at the bottom. So that's the hyperthyroidism, exophthalmosis, definitely appears consistent. So here's just some medical ways you could do this. And again, if everyone answered wrong, now I need to have a conversation. Next. All right, where is the lesion? So this is just to show you guys, you can actually put photos in here. So picture of an EKG, where's the lesion? So clearly massive STEMI. This would get my heart rate going at work. So yeah, it's clearly LAD since all of your lateral leads are gone. All right, so that's Pull Everywhere. Let me show you guys Kahoot. I love Kahoot. Kahoot was made for kindergartners, but we're all kindergartners at heart. So you guys are going to get a pin here. So you're going to go to kahoot.it, and then you're going to type this pin in, and it is going to put you into the game we're going to play. Oops. Sorry, guys. I was trying to close out the others and didn't pan out. So type in 3492441 into kahoot.it, and then it's going to let you pick different names. Now this one, because it was made for kindergartners, if you try to pick a naughty name, it will tell you so, and it will change your name for you. My residents like using, you can actually make emojis. So you can use emojis. So my residents do a lot of that. So there's usually like a jalapeno pepper and see, there we go. Someone's having a party. All right, I'll give you guys a few minutes to log in and pick a name so that you guys can try Kahoot. So this one we do fairly often with our residents. We'll do board review this way. We'll do reading quizzes for whatever their textbook reading was this way. And it's just a fun competition. It keeps people engaged. You can't do it too long. If we try to do board review all day long with this, like anything, like I said, you can't talk to them all day. You can't make them play games all day. Trying to do the same thing for 4.5, 5 hours, depending on how long your didactics are, is going to get old for everyone. But if you break it up, it's a nice way to break it up. So I'll give you guys like one more minute.
So Aaron, I saw your question. Any way to incorporate Kahoot in a lecture, or ways that you found to have residents answer questions in Kahoot while mid-lecture without having to shift back and forth? I've not personally done it with Kahoot, but I've done it with Poll Everywhere. So I'll defer to Dr. Tui.
Yeah, so Poll Everywhere is made to be built into PowerPoints or Keynotes. So that's probably the easiest one to kind of build in. So you would just have your questions in advance. You would make a slide for it, and it would pull up. So that's what those slides were. They were just slides, and then I have the program running in the background on my computer. Kahoot is a little harder because it's kind of intended to just be a single game where you guys are going to compete against each other. I think if you muted it, you certainly could. Like I can switch back and forth right now between my lecture and back to this. So I could do it. I've never tried to. There's also now, Kahoot's free, and I'll show you guys this in a minute when I show you the comparison slide, but there's like a paid version that's about $30 a year. It's really minimal. And it will allow you to actually have slides. So you could theoretically make an entire lecture in Kahoot that's like learning slide, learning slide, learning slide, question, explanation slide, learning slide, learning slide, learning slide. Some of my residents have made presentations like that. I personally haven't, because I haven't preferred to use it that way, but you can. Oh yeah, Carolyn, Poll Everywhere, the quiz function that's like trivia night. I like that one. All right, guys, I'm gonna go ahead and start the game. Here we go. All right. What's the capital of this state? Ooh, we've got some confident people. And again, some of you guys are on the East Coast. When I play this with Californians, they're terrible at it. Montpellier. All right, so So if we were doing something actually medical, I would need to teach you guys a little bit more about this because clearly across the board, we have several wrong answers. All right, Brendan's in the lead, M&M's is second, Megger is third, and Kobe Gine is fourth. What country is this? There's usually background music, but they've been adjusting the music lately. And you guys can adjust the timer. You can make it shorter or faster. Belgium, nice. You guys are good in your international geography. All righty, most people got that right. Oh, cowboy hat smiley face is in the lead. Kobe Gine's next, Miger. Oh yeah, that's the other thing. If someone's being bad or misbehaving, you can actually X them out. I've never had to do that. All righty, third one. And the scores are both based on being right and being fast. Where is this? And so it'll end once everyone answers or when the timer runs out, whichever comes first. Yellowstone National Park, that is correct. All right, most of you guys got it. All right, Megger's in the lead. Unicorn's coming up. All right, two more guys. What band is this? So you can put videos in here. So you could put procedural videos. You could put a diagnostic or a physical exam finding video. Not too many people got that. All right, and the last one for the winner, what sport is this? Cricket, everyone got it right, nice. All righty, and so then we get a final score. Third place is Gator Girl. Second place is Cowboy Hat. And the winner, all righty. Leave page. Okay, and then on the instructor side, which you guys are chiefs now, so you guys are instructors a lot of the time, I actually get a report of that. So if you had your residents use their real names or use a number that it was always them, you could actually get a report and see how people are doing if you wanted to. Alrighty, so there's also this option, like I was saying, there's a teach option where you can actually play a game together in video over class. And then there's an assignment. So again, if you're doing any sort of asynchronous learning with your residents, you could actually just assign everyone to do it at home. And then they would need to use their real names for credit, obviously. So comparison of some audience response systems. So Poll Everywhere, it's free for up to 40 people, which for a good portion of residencies is going to be enough. And then it starts getting a little bit more expensive, $14 per student after that. Slido's free up to 1,000 people. It's a little more limiting. It doesn't have as many options as Poll Everywhere. Kahoot is kind of what you guys just saw. Now, again, you can do learning slides in between those questions if you want to, for like a $30 a year subscription. Socrative is up to 50 people. It's pretty much just questions, photo only, no videos. And then Mentimeter also allows you to break into competitive groups, just like Poll Everywhere, and is free. So let's talk about any questions on that, guys, on using asynchronous learning, or sorry, audience response systems. All right, so other engaging activities. So we'll talk a little bit about small group learning, games, and escape rooms. So small group learning is often just going to be case-based, which is easy enough, right? You can write up some cases, you can write up some questions. There's also some resources I'm going to give you guys at the end where you can find cases that already are made that you can just adjust for your needs. They're fairly easy to create if you are going to create them, and then you just need faculty or chiefs to lead them. So we typically have, we're a smallish residency, so we typically have right around 20 to 24 residents at any of our conferences. So typically we'll do somewhere around 5 groups. So I just need myself, maybe one of my APDs, a couple extra faculty. So from the chief standpoint, these aren't that hard to recruit for. Your faculty need conference credit anyway for your core faculty, so they can come and teach. They don't have to prep anything. They just have to review some materials in advance to like walk everyone through and moderate. If you don't have enough faculty, you could have the senior resident in each group moderate. Games and simulations. So a couple different examples for this. So the left picture is a disaster triage exercise that we made. So basically it was a whole bunch of different cases. It was supposed to be, I think, an explosion at a stadium, and there were 200 patients they had to go work through. They actually only got 50 of those, but they had to green tag them, yellow tag them, red tag them, or black tag them. And then the top picture was actually if they decided they needed the operating room, they had to win a game of operation before they were able to move on and clear that operating room. We didn't want to make it too easy on them. So that we wanted to show that it does take time. You can't just be like, oh, well, these 20 people need operations and there's 4 operating rooms. Just they all went. No, that's not how it works. You have to decide who goes first. You can also do homemade task trainers. So the bottom right is a homemade perimortem C-section task trainer. The picture where she's slumped on the floor is when she realized that the patient who was a trauma was pregnant. So they had to actually cut the baby out, deliver the baby, and then resuscitate the baby. Another example of something we did was neuro charades. I'm pretty sure we came up with the idea when we were very tired, but it was actually very hilarious. So we gave them a bunch of neurological, basically strokes. We gave them a bunch of the different types of strokes, and they had to know what the lesion was, know what deficits that person would have, and then act them out. So again, it's just more engaging. It's kind of funny for the people watching, but it does test the learning, and each group did have to know what the deficits would find. Virtual games, again, I don't think are going to go away just because we're moving back towards in-person conferences. And it's kind of nice because most of these were made out of necessity, but now I think will become a more standard part because either I can have enough residents bring computers that every person in their small group has a computer, or on occasion, if we decide to stay and do virtual didactics, I can still use these. So let me show you guys an example. So this was one that was cruise ship quarantine, beginning of COVID. So it's like a choose your own adventure style. So there's a bunch of different endings that they get, and they get a passphrase for each ending, and they had to have the whole passphrase to finish the game. So they kind of had to go back and forth occasionally, and they had to finish all the different paths. So there's a cruise ship, there's a COVID-19 outbreak. It turns out to be a zombie apocalypse, and you're running around. This one's predominantly ortho questions, actually. So do you want to go right or left? We'll go right first. You duck out, you see someone in your way, and you accidentally punch someone. So this is the picture. What is that an example of? Fight, bite, right? So you make a mental note. What's the first line antibiotic you would use? Anyone? Tridogment. Good choice. And so then you can, again, Google Forms gives you a lot of options. So you can give a nice explanation, or if we'd gotten the wrong answer, we could bounce them back and explain why they're wrong. So let's say someone says no antibiotics needed. Maybe not, go back. So it can you can walk people through a bunch of different clinical cases in this way. And again, it's just a more engaging learning thing. You could send it for asynchronous learning and have residents do it alone. We usually put them in groups of 3 to 4 to have them walk through it and find it works pretty well. Another example that's less of a game, it has less of the story behind it, is this one. And so this is just a neonatal resuscitation. And so it just walks through 35-year-old G8P7 presents in labor ED. You don't have OB, you don't have NICU, the baby's already crowning. What do you do? And this basically just walks you through all of the steps of NRP and to review them with the residents. And so the first thing you do is actually term, tone, and breathing. And so when you're right, it gives you some educational content on that. So baby's born, first you do term, tone, and breathing, stay with the mother for routine care. While not a part of NRP, it would be reasonable to perform an APGAR. So again, you can build in learning content in this that the residents are working through on their small groups. And so again, the nice thing about this is it's small groups that are kind of self-run, and so you don't need the moderators that some of the other small group cases that you would need while they're walking through the questions. These are JavaScript examples. So this is one of our fellows and soon to be faculty members. So he has what he calls WARPs, and they're web-based adventure retrieval programs, because you actually can't call it choose your own adventure. The family that owns those books actually likes to sue people who use that term because it is a copyrighted term. So he calls them WARPs. So these, he made his own website and he uses JavaScript. And it's actually not that hard of a learning curve if you wanted to do something a little more complex than the Google Forms. And the reason it's a little more complex is that it allows you, oops, all right. It allows you to have more options for each thing. So, sorry guys. Let me open the other one. This is the one. All right, guys. So these were made for third-year med students. So you have to pick one. And so it's similar to the Google Forms here. But once you pick what you're going to pick, this allows you to actually walk through the HPI of something. So what do you want to do first when someone comes in? This 28-year-old female comes in and she's feeling weak and dizzy. Do you want to order tests first? Do you want to ask what happened? Do you want to get vital signs? Well, let's ask her what happened. So this pops up when they click that. Okay, we asked her what happens. What are my vital signs? She's a little tachycardic, her blood pressure is good. Okay, she's stable. What's my HE&T exam? And so this lets you build it out a little more aggressively than Google Forms allows for, but it's the same idea. So it's going to be case-based. You're going to be walking through a bunch of cases. These are completely available on this website. John Smart encourages the other people to use them. If you guys want him to give a lecture, which is basically walking through this, you can, but he has no problem with people using his stuff. This is another one that he made that's one of my favorites. It's a critical care billing card game. So critical care billing is important. You're gonna have to know it when you're all grown up and you're billing on your own. So basically you're going through and you're trying to collect all the things that do count as critical care and discard anything that doesn't. And that's how you get points. So whoever has the most cards that are worth critical care wins. And so it really makes you think, like, is interpreting an ABG critical care? Well, it is, so we'll leave that one. Calling a pharmacy because difficult antibiotic choice in a septic patient, that's actually can be critical care. Hyperkalemia requiring shifting, critical care. Causing poison control, critical care. Wow, a bunch of these are today. Adjusting the PEEP, right IJ central line place. That's actually not critical care because it's a separately billed procedure. So these two people can draw a card, and this one, let's discard that one because we don't want to have cards that are not critical care. And so then you just keep going. And so it forces each resident to kind of look through all of these things and see what's critical care and what's not. So transcutaneous pacing actually wouldn't be because it's a separately billable procedure. So we would want to get rid of that. And then when you're done, you debrief and you talk about which ones are right and which ones are wrong. But this is the same thing. It's just built out in JavaScript. And it's a much better way to learn critical care than being lectured on. Trust me, being lectured on critical care is very boring. Escape rooms, which we typically did in person. And so escape rooms are where you have your residents in small groups and they go through a bunch of different rooms or scavenger hunt, however you want to call it. We typically call it a scavenger hunt versus escape room because they're moving between rooms, unlike a class escape room where you're stuck in one room. And so you have a different station set up at each thing where they have to solve a puzzle, answer a medical question, things like that. So for this one, this was a question that color in the ones that have antidotes. So does ketamine have an antidote if it's overdosed on? No. Does cyanide? Does ethanol? Does digoxin? And so they would color in the ones that do, and they would pick the pattern over here that follows the correct answer using a black light. They would flip it up, it would have the correct answer, and it would tell them where they're going next. And so then they're just moving from one room to another, from one game to another, and covering a bunch of different topics. And again, I wouldn't want to do it with them for 4 hours, but it's a nice way to get up between a lecture after a small group session and get them to do something, get them engaged, and have them answer questions on, especially on topics that are kind of hard to be lectured on. You can do something similar virtually if you have to. And so for this, it's very similar. Has anyone ever bought the like home escape boxes or the murder boxes? So it's the same idea. And our fellow actually made it very similar. So this one was the Whisper Killer. And so you just go through this PDF and each of these QR codes takes you to a game that has a medical question or a medical puzzle to solve. You have to solve it, and that helps you answer the question to solve the case. So very similar to those kind of murder boxes at home. So the golden rule for games is, remember, they're fun, but pick your objectives first. You shouldn't be making games just for the sake of making games. And then once you've decided what your objectives are, you can determine if the game is actually is the best way to learn it, or if there's simulation, a competition. Every now and then there's things that just need a lecture. And that is actually still the most appropriate way to learn. So think of your objectives first, what you're trying to actually cover, and then go into the other options. So a couple of resources if you don't want to reinvent the wheel. MedEd Portal has a lot of educational content, specifically TBLs, case-based learning, and then JEM is a journal that has a bunch of reproducible didactic stuff, simulation, oral boards, stuff like that, small group learning. So when you're doing your didactic planning, what I would recommend is that you change it up, right? So maybe from 7:30 to 8:15, you have a lecture. And then from 8:15 to 9:45, you're doing a disaster triage exercise where they're outside and they're working in small groups and they're solving that. And then you debrief that. And then from 9:45 to 10:30, you do small groups doing case-based learning. And then you have your M&M from 10:30 to 11:30, and then maybe you have announcements and reading quiz. So this changes it up. They're doing something different. So any questions on any of that before I get into, I'm going to do a little bit on slide design for you guys, since as chiefs, you will do that.
There was a question asking for the URL for the critical care billing card game.
See that? Sorry, my chat had fallen off. So they're all just on mischiefmedicine.com, but it's mischiefmedicine.com/critical care billing. And I have no disclosures, guys. John doesn't make any money doing this. He just really likes making them, and he doesn't really see the point in people reinventing the wheel, so he likes sharing his stuff. And if you have any questions, he did say I could leave his email up here, so feel free to email him, or if you guys are still doing virtual conferences or you guys are local and you want him to come out and run it for you, you can. But none of these things are super hard to do. Some of them, most of these things, it would take just as much time to make a game, an escape room, or a good TBL as it would to make a good lecture. And that's part of the problem, is a lot of people will give lectures that just aren't very good. So just keep in mind, these can take just as much time as a good lecture. And if it is most appropriate, go ahead and play that. Any other questions, guys? The toxic alcohol one was also made for residents, by the way. I just happened to click on the two that were like more third years, the stuff he'd made for third years. The toxic alcohol was also one that was made for our residents. All right, guys. So, oops, sorry, hold on a second. Lost my, all right, we've got a few more minutes. So I'm just gonna take you guys through some basic slide design stuff. And then, like I said, I'll send the link to Matt so he can send it to you all. It's just a Dropbox with all these slides, so you can kind of basically just steal them. That's the best way to do slide design, is steal someone else's pre-created slides and do it your own way for what you need. So for images and slides, if you're just trying to come up with a good color scheme, coolers.co, not com, it's not a typo. Coolers.co will just give you color schemes that work. And so then you can pick a color scheme, pull that into your PowerPoint or your Keynote, and use that. Google Images, whenever you're looking for an image that you need, be sure you go to Tools and go to Large so that you're not picking a really small picture that's not going to come out right on your slide. And then if it's a lecture that you're going to give in a bigger setting than just your own personal conference, you can also change the usage rights here to make sure that it's not copyrighted. In your own conference, I don't think anyone's really going to care if you use copyrighted images in your own conference. So you can change your usage rights to label for non-commercial use. The best slide design book, if you really want to be good at slide design, is Slideology. It's Nancy Duarte. She does a lot of business consulting on how best to engage people when you're giving presentations. So experiment with shapes and colors for emphasis. So even if you're going to do nothing else, but make normal slides like everyone has always done, at least make some changes. So make your biggest point larger, or change the color of your biggest point, or make the shade slightly different, or pull your biggest point away. So change the proximity. So that's a couple of different ways that you can emphasize things. You can experiment with text size and position. So you can move around, you can move or enlarge your biggest point on a slide. For data, make sure you articulate the conclusions that you want your audience to adopt. So if all I gave you was this chart on the left, I don't know what the point is. Is the point that we were at a low in Q2, or is the point that we were dropping during Q1, or is the point that we've been rising since Q2? I'm not sure. So make sure you're actually emphasizing that point if you're giving data or some sort of chart. So in this case, the point was that in Q2 we were at a low. Toolbox for Keynote or MS Office. So this is a really neat application that can give you a bunch of different icons, and it can give you charts, and it just gives you a bunch of pre-made pictures and images and charts and graphics that you can use. So I like Toolbox for Keynote, but MS Office is a similar thing for PowerPoint. So that is an option. eDraw will also work. So this allows you to make infographics for Mac, Windows, and Linux. So this is just a website. So if you need to make an infographic, if you're trying to resource.
Dr. Tui, you got cut off right mid-sentence there.
Sorry, it's just a nice resource if you're trying to explain evidence-based medicine, or you're trying to explain a more complicated concept to make your own infographic. Takes a little bit of time, but often worth it, especially if it's a lecture you're going to give over and over again. PictoChart has educational pricing, but same thing. It just lets you make infographics. The eDraw is free. Canva is pre-existing slide design. So you can go through and pick a pretty slide deck, and it will actually just give you a bunch of different slide decks, similar to what PowerPoint and Keynote already have, but they're much prettier and they're much more elaborate. So it's an option for you. Be a little careful with Canva. You can go down the rabbit hole and get a little lost. So really quickly, a slide off. These are my colleagues who made these slides. I did not. But a couple different ways. So an objective slide, right? Every lecture has some sort of objective slide, or should. So this is how it typically looks. It's kind of boring, right? How can we spice that up? Well, you can use icons, and it doesn't have to be in a vertical format. You can walk across. So in this case, I'm telling you, we're gonna differentiate various examples of slide design for types of slide frequently used by medical educators. We're gonna learn techniques to create effects in PowerPoint and Keynote. We're gonna learn general concepts. So just adding the icons, and this is already much more eye-catching and much more engaging than the very, very plain slide. Another way to do it would be this way, where you just kind of have some sort of a single icon, and then you're moving through the different options on the side. And again, I'm emphasizing the one I'm talking about. Another one is charts. There's a lot of different charts that we have to make if you're giving lectures in medical education. So for example, start triage. So here's the one from the textbook. Not very engaging. It's kind of hard for me to walk residents through this if I'm teaching this. I could make it way prettier. So I could incorporate some of the colors. I could incorporate more kind of utilize arrows better than this does, right? And so this is much more engaging and much more easy to understand on a slide than this was. Another way is this person used the exact colors. So they actually used the yellow, red, and black versus green. And they kind of walked through. It's the exact same slide. It's the exact same chart. It's just more varied. So this one is just board review, right? If we're gonna do a board review lecture on temperature-related illnesses. So how is heat transferred? Radiation, evaporation, conduction, and convection. So this is just reviewing the different ways that you can cool off a hyperthermic patient, and just adding images and using a little bit of shading. And this is much more engaging than me just putting a bunch of text on a slide, right? Same thing here. Now here, we're really just using the background icon because we're talking about hot things. So it's a desert. And then we're comparing and contrasting heat exhaustion and heat stroke. Oops. There we go. Or hypothermia. Now it's a frozen tundra, and you're comparing mild versus severe. And yes, there are words on the slide. If you want to get your point across, there's always going to be words, but we're trying to minimize the number of words, and it'll provide visual emphasis. So the various treatments for hypothermia. And so again, you're just using images to kind of remind people what they're looking at, engage them a little bit more, and you're trying to minimize words as much as possible. So here's a different example of it. So this one more just went with colors, and then they're using just emphasis and extra words that are various color and kind of pop out to provide their emphasis. Case presentations and M&Ms, let me just get through this one and then I think we're out of time. This one you guys are gonna be doing a lot, right? So instead of just putting all the words, you could use something like icons. So this is your history and physical exam versus your vitals. So it's a little bit easier to read and it's a little bit more visually pleasing. For your physical exam, there's lots of different icons you could see of just bodies, so then you're showing where the different findings are. So that's one way you could do it. For your images, the wife shows up, gives further history, you provide the CT scan, you have the results. An alternative way to do that, same thing, using icons and images. This one walks through your subjective, your objective, your physical exam, and your differential. So here's your subjective, here's your objective, here's your physical exam, and there's your differential. Okay, so just a couple of different examples. There's more in here, guys, so feel free to grab the slides and swipe them. I have them in Keynote as well as PowerPoint, so whichever one is your preference. So does anyone have any questions for me? Anything I can answer? My chat keeps closing, sorry.
I can't emphasize enough the need to minimize the number of words on slides. And there are so many people, when they put together a slide, they put all these words up there that no one's going to read, and then they read you the words to you, right? So please, 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 the words on the slide are not the words that you say out loud. The words on the slide are like the high points, and then you talk more.
You guys are supposed to be the show if you're giving a lecture, and the slides are supposed to assist in understanding or assist in emphasis, but it should not literally just be you reading slides. Because if you're going to do that, just give them a document and have them read it, right? So those are just some examples. Do we do systems-based didactics? So we do. We have I think it actually turns out to be, it's an 18 system. Yeah, we have an 18 block rotation that we do twice. We're a 3-year program. So yeah, we end up doing respiratory twice. We do GI twice. We do cards twice, just because those are such big topics. PEDS is built in throughout, and then everything else is once every 18 months. So we do a systems based. Every now and then, you know, someone will be available or a national speaker's in town, and so you fall outside of that. But in general, we do try to stick with systems based. How many residencies out there have required reading? How do you manage that? I actually know the answer to that because I recently asked Court this. The vast majority of residencies have actually moved on from textbooks. And I apologize to any of your program directors if I am running things for them. We were still in textbooks up until last year, and that was why I was kind of re-examining this, because we used to use Adams, and Adams has been discontinued. So I was gonna have to change to a new textbook and was trying to figure out how we're gonna adjust the curriculum. And more than half of the program directors responded, we don't use textbooks anymore, that they used online learning, they used FOAMed, they used Compendium, which is the MRAP textbook, that most residencies at least book you guys through EMRA, and you're all EMRA members, which means you get MRAP, so that means you have MRAP Compendium. So a lot of residencies said that they actually assign from there, and probably about a third of them said that they assign through Rush Review. And I find that Rush Review is great for learning. The explanations are excellent. I don't think the questions are really board style. I don't think they're very similar to the in-training exam. I think Peer and HippoEM are better for that. But anyway, so I discovered most residencies do not use textbooks anymore. They have some other sort of reading schedule. I would say most have some level of reading schedule, but I think more people are turning towards really quick books like the Black Book from AEM or online resources. Any thoughts on making Journal Club more engaging? Oh God, Journal Club. Journal Club's hard. It is so hard to teach evidence-based medicine well, and it is so hard to do it in an engaging way. So we have a curriculum that has a bunch of the evidence-based medicine topics that they absolutely have to know. We found either YouTube videos, or we have a couple of really short, like 5-minute lectures that cover them. That's like, hey, here's your positive predictive value stuff, and here's your sensitivity and specificity as a reminder in case you forgot all your biostats from med school. And we do that for a brief period at the beginning. Then we break up it. Then we usually have like one article that we thought was very interesting or very engaging, and we kind of have everyone go through that, and then we break them into small groups. So I find small groups is one of the easier ways to kind of just make sure people are somewhat engaged. So we usually have 3 or 4 faculty members. Everyone reads a single article in their group, so they can really focus on that one article and tear it apart. And with that small group, it's easier because the residents are more vocal, and they have to be. So they'll talk about what they like about the article, what they didn't like about the article, the problems they find in the article, which is of course the point of Journal Club, right? We're trying to teach you guys to be critical of the literature. So I found that works pretty well. It still gets old. So we've started incorporating a few other things. So we actually used Kahoot, not to answer questions, but to see where people were on various subjects. So kind of like that first slide and poll everywhere. So it was really great when we did COVID one, and we were like, who's antibioticing all of the atypical pneumonia, all the COVIDs that get admitted to the hospital? And it was all over the place. How many people are doing a walking pulse ox before we discharge them? And it was all over the place with residency and faculty. So it was really interesting to see how varied our practice was. And then we went in small groups and reviewed several articles that covered that and answered the questions. So I really liked that. So you can pick that. And then one of the last things that I think is one of the best ways to do Journal Club, but it's labor intensive for residents, is debates. So pick topics that are not definitive, right? So is contrast-induced nephropathy a thing? Should we still be cooling people after cardiac arrest? And as you're doing that, you break your residents into 2 groups, you give them 3 or 4 articles in each group, and you have them debate. And it's so fun. The residents are really good at it. They get into it, but it does require like an hour or 2 of prep for them to read a bunch of articles and really prep their arguments. They remember them though. I mean, 2 years later, we had one resident who was finally a 3rd year who was still making his point about contrast-induced nephropathy. He was very passionate it wasn't a thing after his debate. We only do that once or twice a year because again, it's labor intensive for the residents and they didn't like doing it every month. So again, I would say just like anything else, the key to Journal Club is break it up, make it varied, don't do the same thing every month. And in that, I think having chiefs run it is actually one of the better things because, you know, then you've got a different chief each month running it and you guys are going to come up with different things. But yes, it's a very hard thing to do. You've got to decide, do you really want to be critical of the literature or do you want to cover things that matter and that are going to change their practice? And those are 2 very opposite goals. Oh yeah, so one person commented, sorry, when we were talking earlier on content that they use Foundations of EM curriculum. So that's a really good resource for case-based learning as well. I really need to add that to the resources slide, I keep forgetting. So they have almost every topic systems-based, and it's just a bunch of cases that you can do in small group learning. They actually have different levels. They have PGY1, PGY2, PGY3, so their goal is to break it out into the levels of the residents, whereas a lot of times I'll actually mix them up so you have a senior that like can help the 1st or 2nd year, but just different ways to do that. With slow transition back to in-person, any others planning to continue offer percentage? Oh, yeah, I don't know. Is anyone else planning to offer that? I don't think it's definitive what ACGM is going to do with that. I don't think they're going to tell us we can't, but I don't think there's any definitive answer on that.
I do think the one thing that came from the virtual was the ability to have out-of-town guest speakers without having to pay. I know that we have had a couple of people that got to come to Florida without actually come to Florida. And if they're people who are reluctant to travel or are big names and are super expensive, but they'll do a drop-in Zoom pretty easily, then that's, I think, a good resource to have for that.
Yeah, absolutely. And so that's why that's one of the main reasons, one of the big reasons we're keeping it, because residents do like every once in a while just sit at home and do conference, and we can get the national speakers and things like that. So yeah, and as others have said, then your residents who are out of town can phone in. I doubt very many residencies are going to keep all virtual because I think it is hard to be sure everyone's engaged. It's very easy to start doing the dishes and pet the dog and work out. And actually, I think you're probably paying better attention if you're working out than if you're not, than if you're messing around your computer. So I've encouraged my residents that they're allowed to do that one, but I think it's just easy to check out. Definitely every now and then someone falls off mute and I can hear the TV in the background and I'm like, I know what's happening, guys. All right, any other questions I can answer, guys? All right, let me just throw my email in the chat. Feel free to email me if you have any other questions or thoughts. And thank you guys so much for having me. This is always such a fun session.
Awesome, that was great. Thank you so much. We really appreciate it. Your suggestions always permeate all these other programs, and everyone has new ideas and exciting ways to make conference way more engaging because of the litany of ideas you give us. So thank you so much. We tried neuro charades last year. I remember telling you like, that was amazing and I want to do it. We tried it and loved it. It suddenly changed neuro from the most hated topic to cover to the best topic, I think, of the year. So
fun.
yeah.
We literally were post-night drunk when we did that. But like, it's so much fun, guys. I recommend everyone try.
Yeah, it was brilliant. It was brilliant. So, okay, well, why don't we've got about 5 minutes. So why don't folks take a little bit of a stretch break? I'm going to throw a question again in the chat to kind of lock in that learning for you. Okay, gang, start coming on back for our final formal session of the day. I promise this one will not disappoint. It is probably one of my favorite sessions. Don't tell any of the other presenters because I always gain a lot out of it. So it's my distinct privilege to introduce Dr. Cynthia Price, who is here today. She is an assistant program director at the University of Connecticut Emergency Medicine Program. She is a ball of energy and a clear advocate for leadership growth, but in a balanced and thoughtful manner. And so that is one thing that I really appreciate about her. So she is going to talk to us a little bit about, you know, the Chiefs, Cynthia, just to give you a background, we're a little bit nervous about this middle management position and all the stress that comes with it. So she's really going to give you some, I think, really tangible and awesome ideas of how to manage that. So take it away.
Awesome. So thanks you guys a ton for figuring out how I can move forward. Why are my slides not advancing? There we go. Okay, I have no disclosures or financial interests. And I also totally appreciate the middle management group. If you're not worried about it, you have not paid attention to the role of chief resident. It is distinctly a role where you guys are caught a little bit in between residency leadership and hanging out with your cronies. And it's an awesome and fun role to have, but it is also fraught with putting a whole lot on your plate and having a ton of responsibility. And so what we're going to do today is just talk a little bit about how you can be well. And I'm going to ask you, what do you think some barriers are? And you can just pop those microphones off and just actually answer me. Nobody's going to be looking, but you should be talking about some of these things that you're concerned about. When we are there in person, it's totally a different experience to sit at the table with your co-chiefs and kind of discuss and figure this stuff out. So while you guys are separate and apart on your different screens, be thinking about the next time you're going to come together with your peeps and think about how to set the tone for the rest of the year. You guys are probably all at the place where you're going to be taking over the responsibilities from the remaining chiefs that are there that are getting ready to graduate. And so this is the time to develop some stepping stones. And we'll talk about some of these stepping stones so that you guys can have a really successful year while you stay well. So today we're going to talk a little bit about resiliency, and you'll hear me say resiliency. You'll hear me say wellness. You'll hear me say work-life balance. All of that I'm kind of putting in the same basket today. A lot of times you'll go and talk about things that assess blame, and that's why we need to be resilient. Today, we're going to put all of that into one catch basement so that we're not distinguishing too much. We are going to identify some barriers to wellness and resiliency that are really particular to chief residents. We're going to go over the 7 C's of resilience. How can we develop some resilience? And then explore the stepping stones. How do we get you guys through this and make you well? So why am I doing this talk? As Matt said, I love talking about wellness. This is my 4th talk today, and 3 of them have happened to be on the topic of how do you keep yourself well in academics, as a resident, in residency leadership. during COVID? What are the things that we do to keep ourselves well? Osler said, don't talk about anything if you're not passionate about it. I'm passionate about trying to figure out how to keep us well, particularly our residents, which you guys stepping into chief residency role probably have and share some of that passion to keep people well. So resiliency, wellness, what do you guys think it means? Let me hear you. Talk out loud. What do you think resiliency? What do you think wellness means?
Having balance between what you're doing at work and what you're doing at home.
Absolutely, Dan. Thank you. Who else?
I feel like resiliency is like the ability to face advocacy and bounce back in a healthy way.
Absolutely, Emily. Thank you.
Not losing yourself in your journey throughout residency and why you fell in love with medicine.
That is a hot mess. How do we hang on to ourselves? For sure. Great. Who else? What do you think? Do you guys talk about wellness? Have you been talking about it? Do most of you in your chief year or chief duties have somebody or some piece of your job that involves wellness? I see some head shaking from the two of you that have your camera on. Yes, Josiah, I'm looking at you. So yeah, well, all of us have something to do with wellness, right? I do think we should talk about it a little bit more. We want it to become normative. So what do we think it means? If you look at balance, if you look at wellness, what we should know and think about it, it is a process. It's not a static state of being. It's continuously moving towards a greater awareness of yourself and the way in which our environment, our relationships, nutrition, stress, and all of the other factors influence you. And certainly we had a lot to think about during COVID. I think about my chiefs during COVID, what changed, what didn't change, how they were successfully able to try to keep the balance off and on and moving when our world was changing around us every day. So if we think that resiliency and wellness looks like balance, but what we have to know is it's individualized. What makes me well is different than what makes Matt Stoll well, right? Or what makes Carolyn well, right? All of us, Dr. Holland has a different set of work responsibilities than what I have. What makes us energized and productive is different for all of us. Who's got priorities that are different? My priorities might be to water my plant one day and to go to Africa the next day and try to save the world, right? How do we personalize our growth professionally? And if you look at this bottom line, unfortunately, you guys as Chief Wellness might know that wellness and resiliency is better defined by its absence, right? When are you going to be the ones that are recognizing a problem in your program or in your co-chiefs? So why are we talking about this? Work-life balance, which is, as somebody just said, about not losing ourselves. Emily, I think it was. We look at this, and when it first started being topic of conversation, it was for working mothers, right? That whole 50s where people were staying at home and kind of staying in their place, that was changing, and people were trying to figure out, how do we put women in the workplace and then want them to still be responsible for children and a household? And as we got along to the 80s, structural changes took place. Lots of benefits were added, flex time, maternity leaves, and men also became concerned about their own work life. That really solidified during the 90s. And now people were saying, yes, if there's maternity leave, there's also paternity leave. And how do we put those together in our company? And as we have come into the 21st century, it's more challenging than ever with us trying to figure out work-life balance, knowing that we are coming out of gender roles, or gender fluency adds to who decides what role people have, and how our workloads predict other stressors. What's going on in our political world? What's going on in our COVID world? What's going on in diversity and inclusion in our LGBTQ world? all of that is changing. And so we have a predictable increased load of our stressors that stress our work-life balance. So I will tell you, it doesn't mean that there's an equal balance. I will also tell you that it is changeable in time and that there is no one way that fits all. And so when we are looking at, and this was something that people just took this poll 3 years ago, and it said, well, what are your top priorities for the next 3 years? So they are top physicians, but absolutely, we're going to ask this to you guys. Some of you are chiefs in programs where you'll be doing an extra chief year, as well as 4-year programs. But for this particular study, it's like, what do you want out of your life the next 3 years? And on average, only 2 of the 10 were work related. So that means 8 of the 10 life goals have nothing to do with work. So how do we morph our struggle to be successful at this chief role, to obtain some leadership goals, and take care of the 8 out of 10 things that say, this is what defines me and this is what keeps me happy. So if you are looking at those goals that revolve around friends and family and relationships and fitness and health, you just can't put this in the money category or in the time category or in the respect category. I wish I could tell you that being chief resident was easy and people are going to respect you and you're going to walk on water and people are going to applaud when you walk in the room. Not the case. This is not the case. So let's try to look at a few other things than what we're talking about. We know we've got to achieve this balancing act, right? Family, career, and self. There's a little tiny intersection in the middle. So what do you guys think are going to be specific issues to you as chief resident? Pop those cameras on and mics on again. What do you guys think your specific barriers are going to be? Josiah, what do you think your specific barriers are going to be?
I think sometimes finding a balance between time at home with my wife and balancing the duties that you face as a chief is something that I'm a little bit worried about maintaining the correct balance for.
Absolutely. Nishad, what about you?
So I'm one of the scheduling chiefs entering in, and already for the 2 months I've scheduled, I've just noticed that I'm giving myself the worst schedule of anyone because 1, I don't want to screw over anyone else, and then 2, I don't want to hear anyone whine about their schedule. And so far it's not been bad, but I wonder if that's something I'm going to burn out moving forward on.
Right? Like Emily again talked about losing yourself. If you have to be the chief that always sucks it up worse and gives yourself the worst schedule, how are you going to stay found? How are you going to keep your footing? What else do you guys think is going to be a particular challenge to you?
I'm personally worried about losing the relationship I've established with my other co-residents.
Yeah, because guess what? You can be besties with the besties, but the besties that aren't labeled as chief think that maybe because you're a bestie, you might give them a better schedule, or you might allow their shenanigans to go on. And so you do get to keep your friends, but there is clearly a change in the relationship. It is going to change. No ifs, ands, or buts about it. I'm hoping that with your co-chiefs, you will be developing some of these things, but some new besties, but your old besties, what's going to happen there? What other issues? Nicole?
I think some of it is just trying to balance the medicine portion. I think I often, emergency medicine is a lot of learning, and so balancing the clinical side and not, getting too overwhelmed with, that, not that, being chief is important, but it's like an extracurricular because again, we're going to be practicing in 10 days in pretty much a year. So that's kind of scary, the personal thing.
Yeah, because guess who we look to be leaders, not only in your residency, but clinically, right? You're a chief, you got something to prove. The nurses, the other attendings, they hear, oh, you're a chief? Yeah, you got to walk a little higher on the water of the strata of residency because you have been singled out and chosen for some skill set that you have that should be always demonstrative in the clinical realm, the academic realm, the ITE realm, the communication realm. There are expectations. Does this sound fun? Are you maybe second guessing all of this? Stephen, what about you?
I think it's I mean, on the same point of managing expectations of others and keeping things fair, but also cordial among co-residents is going to be a good time sink.
Yeah. So time should be something that we are concerned about because you don't have much to get there. I will tell you, if we start looking at this competing demands, I don't know who's raising your hand, but anybody got a family at home? Anybody got other responsibilities to a significant other that you didn't go into residency to lose that relationship? And now you have residents and the program needs, you know, and there's a call out at 5:30 in the morning. This morning, I'm getting Tiger texted at 5:30 in the morning. Hey, we got a call out. So not only is my chief rolling out, I'm rolling out too. We got to pull up the computer. Let's look at MedRes. Who are we going to shuffle? Right? What about your personal needs? Fitness? Anybody like going to the gym? When are you supposed to do that? What about keeping your own health metrics? Forget all the rest of this. What about some alone time? Right? When you're not with your cronies, you're not with your significant other at home, but when do you get to have some downtime to yourself? Oh my gosh. And then there's research and academic projects. You guys are supposed to be teaching. You still have to be the recipients of teaching, as well as the things that we require, again, you as chief, to do with rounds, med student sessions, all the rest of the things that we have on your plate. And then you got to be in more than a few committees. Everybody want to do committees. And guess what? Now that they are virtual, they want committees at 5 o'clock at night, 8 o'clock at night, 6 o'clock in the morning. All of a sudden, the boundaries of when people want to schedule meetings have changed with this virtual platform. All of them. And then what are your own individual interests, right? So if you want to be the ultrasound person at your place and maybe are considering a fellowship, you still got to learn ultrasound. You also maybe still have to learn SIM, or maybe you're the leadership and advocacy person and you still have to pay attention to some of the national commitments that you have, or the EMRA rep, or all of the different things that we have. These are what we call competing demands. And so we're going to have to figure out what to do with them. So what are some C's of resiliency that I think we should just review before we go over some of the stepping stones, right? So if we look, there's competence and the ability to know how to handle stressful situations effectively is the entire reason why you guys have been on Zoom. It is the entire reason why there are things like Chief Incubator and LIM and all of these things, because we know if we can get you competent to handle the difficult stuff, that you will be more resilient because you'll have some competency. And I will tell you the biggest struggles of last year was some of these things that normally happen being taken away by COVID, and then us not having the skill set to get people ready for the big jobs ahead. That was just a difficult time, right? It requires having the skills to face challenges and for us to have the opportunity to practice so that when you get with your cronies and they say, hey, dude, can you throw me an extra 2-day weekend in there because I'm your friend and I think I deserve it because I've had a rough life. I want you to be competent in being able to handle that. The next one is confidence. And the entire way you build competence and confidence is by being competent. So what are your co-chief's individual strengths? Who's going to be the cruise director, right? Who's going to be the hard ass? Wait, did I say hard ass? Who's going to be the hard butt that says A plus B equals C? And this is how I'm staying in my lane by very clearly delineating these are the rules and we're going to stick to the rules. Because on the other side, you got to have the hugger. right? Who's going to hug it out? Who are the people who are, somebody is approaching to say, my life's really rough. And although your life might be rougher, you have to give up the ghost and say, come on in, let's go for a hug. Let's get a cup of coffee. Let me hold your hand for a minute. How can we make your day better? So when we as a group in your own chiefdom identify each other's strengths, you know that going in confidence, you don't have to be responsible for all of the different ideas, right? You get to pick and choose some depending on your co-chiefs and their individual abilities. So this is one of those things we would talk about at the table, right? Well, what are your strengths? What are your strengths in the person next to me and the person sitting on the other side? How do you stay connected? So we already have mentioned this a couple of times. How do we stay connected when you have chiefly duties and you also have friends? You want to go play on your soccer league. You've got family. You have your community groups, maybe your church or your place of worship or the Girl Scout troop or Big Brothers, Big Sister. How do we keep you connected even though you have this whole new set of responsibilities? So then if we look towards all of those things, probably the essence of chiefdom is defining your character, right? So do you employ a strong sense of self-worth and confidence? How are we going to build that up? If you've got one strong chief and one who maybe doesn't talk as much or as out loud, how are we building everybody up so that everybody feels they have self-worth? You don't want to have 4 chiefs and everybody is, 70% of the hubbub is about one chief and 30% is about the other 3. How do we employ to build everybody up in the character that made them go out for chief and then have that be their sense of character where everybody feels appreciated? How are you responsible for sticking to your values? And how do we get you guys to a place where you can demonstrate a caring attitude towards other, right? So character, even for emergency medicine, we are the ones that take care of the sticky people, of the one that have bugs, of the people that nobody else wants to take care of. Think about some of your residents like that. Some of them are prickly, some of them stink, some of them nobody else wants to take care of. Some of them speak in a different language that you've never heard before. And you as a chief have to demonstrate a caring attitude towards all of them. Contribution. So I think it's a great idea now when you are developing your resiliency to figure out at the beginning of this year, what's going to be your contribution? Because I think it will help, as Emily said, for you not to get lost in the whole thing. So define your contribution now. Are you going to be the peacemaker? Are you going to be the analytical schedule person who can always take a second look at that schedule very quickly and get to be the one who likes to work with the markers and the highlighters in different colors? What's going to be your contribution? Are you going to be the mouth of the residents? Are you going to be the ambassador for your program with all the other different chiefs of different specialties that you want to have? All of them. So think about your contribution now, because I think it will help you keep defining the way you want to consider yourself. Okay, I'm just going to keep hitting this button and hope that something happens. I don't know why it's stuck. Pretty sure we have one more C left. I got it. Control. So this is the last thing, right? I think as chiefs, you need to be able to maintain control over your decisions and actions. And the way to do that is to make sure that you are keeping proper communication with residency leadership so that you guys are all working as a cohesive unit. Again, you're in this very interesting place where you are the voice of the resident, but you are also beholden as the voice of the program back down. So you are in the middle, as Dr. Stoll said, the middleman. You are part of that. And so the way we look about how to develop resiliency is to maintain control. And the way to do that is just to make sure that you are stepping out there as you are developing your resiliency and getting along with your co-chiefs. You are making sure that that control stays. So let's tell a quick story really quickly. A rabbi, a priest, and a Baptist minister were out in a boat fishing. The priest said, "Oh my goodness, it's such a lovely summer morning. Let me go get us all some coffee so I can make sure that we are having a lovely day." And they're out in the middle of this lake watching the sun come up. And the priest goes over the side of the boat and he walks along the water and he goes to get the coffee and he comes back. And after he comes back, the rabbi says, "Oh my goodness, the sun is shining, the birds are singing, and we've got coffee. We absolutely need some bagels." And so, wow, let me go get some bagels. And so he goes over the side of the boat and goes to get some bagels and comes back. And so then we've got the minister and he was there and he was like, "Oh my goodness, we need some jam to go on these bagels. And so let me go and get some jam because it's such a lovely day." But the Baptist minister goes over the side of the boat and oh my goodness, he falls in the water. And he's sputtering around going, "I don't understand. How could you guys stay on top of the water?" And they both look at him and go, "Well, it's pretty evident to us that you don't know where the rocks are." So these are the rocks that we are going to talk about now to keep you guys afloat of the water. We want everybody to know where the stepping stones are to keep you awake, alert, and alert. So if we look at your professional stepping stones for your chief residency, you got to mold your environment. What is going to keep you well? You guys need to get together as a group and say, where are the toxic areas or where are the opportunities for us to impact a positive change? You need to mold your environment. What is that going to look like? I think it should look like you guys meeting together once a week, or you guys meeting together every other week to make sure at some point you're talking about yourselves and sometimes you're talking about your program. I think you have to build a support structure within each other. So again, it's going to be great when you guys have your friends, but the real people who will be able to support you will be your fellow chiefs because they know. And if you have not developed the relationships with them yet, I'm hoping that the goal of the next couple of months while you guys are being eased into your roles will be figuring out how to support each other. Take control and have a plan for emergencies. This is part of your professional life. Earn respect. So if you have to keep walking through and going, "Respect me, respect me, respect me, I'm a chief," I will tell you respect has to be earned and your actions speak louder than words. So you might be the book of chiefdom that people are reading. They're not going to sit down and look at the definition in the book that says, "Oh, you got to do this, you got to do that." You're going to be who they're looking at, and you are going to be the one setting the tone. And that in turn will earn you some respect. So you guys are going to need to set boundaries. And just like in our clinical world, what is going on with other people that treat you poorly or maybe have some difficulty with communication, you got to be like a duck and figure out how much of this you cannot take personally. If somebody is disappointed with the schedule that they got, you have to figure out a way to say the schedule is fair, it's been developed, and us as a grown-ups expect you to put your request in 2 months in advance, just like everybody else. I'm sorry, I can't change things for 30 people because the weekend before the schedule came out, you decided you need more time. And when they are upset, don't take it personally because it has nothing to do with you. If you popped your cameras on and shook your head, I want you to say, don't take it personally. This is a power thing. So what you need to do is take your role and responsibility very seriously, but you can't go home and absorb all of the energy that comes from the myriad of different things that you have to deal with during the day. Set boundaries and don't take it personally. I think it's very helpful for you guys as chiefs if we keep looking at professional stepping stones. Identify a mentor with experience in your arena. So if my chiefs who are leaving and graduating or departing, but one or two of them were staying around, they are available to act as mentors because they have been through it. So we've got some of those. We've got some chiefs that have actually stayed on from their years and have joined as attendings, maybe even core faculty. Identify a mentor with experience in the areas that you want. If you guys are organizationally challenged, this is the time to get this skill that is going to be a life skill for you for the rest of your time on earth. This is the time to hone your organizational skills. What is the skill for your clinical advancement, for your academic advancement? What is going on in your home? And how are you keeping yourself balanced? All of that has to be organized. You will get yourself in so much trouble if you are disorganized during your chiefdom. Figure out who amongst your chiefs are the most organized, and then put those skills together, right? So if everybody can get on one calendar so you can divide up what the things are, who's setting alarms, who's figure out who's got the best tricks and skills, but everybody has got to get organized. Otherwise, you are spinning your wheels and your time is so precious. I will say one of the biggest stepping stones to your chiefdom should be getting your organization together. Simplify everything you can, right? So who was it? The guy who died, Steve Jobs. That was a bad way to say that, but you know what I meant. But you knew every day the man wore a black turtleneck and a pair of the same pants, so he did not have to think about that. Of all the things, he's like, you know what? I don't want to think about clothes. Every day I'm going to wear a blazer, and I got 14 black turtlenecks. And every day he put on the same clothes because he was trying to simplify his life and routine so he could devote some of that time to other things. Figure out where your resources are. Where are your resources at the university? Where are they in the community? And where are they nationally? Are you guys all going to be on a listserv? All of the things that we've had in the past for chiefs, right? When you guys come in and are able to get all on one thing so that you can pool your ideas so you're not doing the work again and again and again. At the university, how are you guys as chiefs structured with chiefs at other programs, right? So the IM chiefs and the medicine chiefs and the family practice chiefs and the OBGYN chiefs, how are you guys all together to make sure you are able to work in tandem? This is so important, especially for emergency medicine, because we play in everybody else's backyards. So the more you can reach out to those chiefs, and maybe again, all be on an email or a listserv or a blog or a Slack or something, you guys figure out your strength by putting yourselves together with other chiefs at your program. And then out in the community, what else out there is there for you to hone your leadership skills? I know that in the Connecticut region, they just had a all-comers women in leadership and medicine conference, a 4-hour conference over at one of the other hospitals in town. Everybody welcome to come. Wow, how fantastic would that be as a chief to get some free leadership skills? So make sure you're looking at your resources and getting those. If we switch from the professional stepping stones over to the personal stepping stones, I will tell you and tell you again, you have to make your resiliency and wellness a priority. I can't want that for you more than you want it for yourself. I can love you and encourage you and support you, but I can't want wellness for you more than you want it for you. We will fail at this together. So we need to make it a priority. The easiest way for you to keep yourself well and balanced is to keep fit. That looks different again for everybody, but you need to watch your diet, your exercise, learn to sleep and sleep well. Not all 4 of you or 3 of you or 5 of you have to be on call at the time. So if the scheduling chief is the one that's on that for 24/7, we will figure out that schedule. And for a month, you might have a bad month, but you know the other 9 months of when it might be your opportunity to do scheduling that you are going to be able to sleep through the night outside of your clinical responsibilities, right? Sleeping is so important. Coordinate your career with your family. Your family needs to know that just because you are not working clinically does not mean that time belongs to you. My family all the time, I don't understand. What do you do the other 20 days of the month that you're not working, right? That's going to be you. And when we have the interest meeting for people who are interested in being chief, the wives, significant others are able to come. And one of the wives said last year, my 3 and 4-year-old are not going to understand why daddy is at home and daddy can't pay attention to them. So what is available here so that he can get his work done? And when he's home, he's able to step into the role of father and significant other, right? That is a significant other coming and asking. And I say, oh, we got something for you. We got a chief's office right here. We've got scheduling right here. We'll be able to tell you a year in advance when the schedule's going to be screwed up and when you cannot rely on him to be father and daddy at home and when he's going to need to stay here and get some extra work done. It makes sense. And if you guys don't have that, you should have it for all your residents. Have an open night. Let the significant others come and figure out, although you are working 18 shifts a month, what do you do the other 12 days? Let them know that there are some responsibilities. Put those things out there. It will make your life as chief so much easier if your residents have significant others that understand all of that, but also particularly your other halves understand that. Talks again, setting boundaries to make sure that happens for you and making your money work for you. You guys are on limited budget for what we have decided to give you for whatever that chief is year. For a lot of times, and particularly in our residency program, for me in emergency medicine, my currency is not money. My currency is time. It's the same for chiefs. We give our chiefs a shift reduction as opposed to more money, right? And it doesn't always equate out. I know that for those little few shifts that I get off as an attending does not equate to the 100 hours a week that sometimes I am in my office for, trying to develop a DVT for working in the office for 10 hours at a time, right? So make the currency work for you. If you are organized and do the rest of these things, and you have a little money to pay the cleaning lady or to get the lawn mowed by somebody else, you know, make your money work for you so that your currency, whatever you decide it is, actually works for you in your chiefdom. Does that make sense? I see a couple of heads shaking. I do think this is important as your chiefdom develops and you get further and further in. You have to figure out when to leave work at work. Create a ritual to help you get there. Set limits around how much work you're doing at home and how long you talk about work at home. So if you've got a significant other that is in medicine or not in medicine, figure out the boundaries. My mother used to come home from work as a teacher and she didn't want to see us 4 little girls for a minute. She set that timer on the stove. I need 20 minutes to pretend I have no children. And we would just stand at the kitchen door and wait until we ding, right? So figure out what you're going to do. Where are work-free zones? Put a piece of yellow tape on the floor into the bedroom so that you know that your job does not come into your pillow talk. I am teaching you things about your chiefdom that you should develop for habits for the rest of your life. Figure out where your protected zones are. Schedule play dates for you if you're becoming too busy. This goes back to being organized. A few more quick stepping stones. We're almost done. Learn what you need to let go. Learn what you need to let go. Some things you will figure out what to let go. Some things you will need to say, I need to calm down into my habits, or some things you'll need to say, I can't play soccer for the 2 months that I'm the scheduling chief because it's not fair to the team. So I need to let that go for 2 months and take a hiatus. Make your hobbies a priority. Create a personal inventory. When you guys are meeting once a month, check in with each other first. Are you getting where you want to be? I know you're doing your chief stuff, but are you paying attention to your ultrasound stuff? Are you paying attention to applying for jobs and getting that stuff? You guys make sure you're creating a personal inventory for each other. This other thing is huge. We are a team. There are some lines that say you are part of a bigger network of physicians, right? We as physicians are not great at asking for help. We want you, I see Nishan shaking his head. We are not great at asking for help. Guess what? It is a sign of maturity that you know when to say, this is becoming too much. You get together with your co-chiefs and say, I need you guys to protect me for a weekend. Although I'm the scheduling chief, I got a lot of stuff going on. And so I'm going to need some, and you guys close ranks, right? Where does the help need to come from? You know what? I can't get this done. Or you know what? Today I need to step away from this duty because I need to make sure that somebody else is okay. So can I hand this off so I can have this? Ask for help when you need to ask for help. It will make your year so much better because you will figure out how to share the work between each other. You'll also figure out what work to put back on to your residency leadership. Hey, Dr. Price, we are getting in over our heads with this situation. And I need to take that back on my plate so that I can free you guys up to do what you need to do. So asking for help, not a sign of weakness. Changelessness. I'm not going to talk a lot about all of this, but you just should know change happens. You got to grow with change. So if COVID taught us nothing, it taught us to be nimble, I would hope I say. And during your chief year, you're going to need to learn some nimbleness. For the last 20 years, if it's been done one way and all of a sudden you can't do it that way, put your heads together and figure out how to deal with the change. Change is going to happen. There are some things that are rock solid in your life, and there are some things that you need to work with changing. So we make that happen. I will say it again, work-life balance stresses self-responsibility, which leads to resiliency. Acknowledge the issue, design your life, days versus months versus years, elongate your time frame, approach everything with balance. Let me just give you a couple more tips and we'll be done. Don't feel guilty about hiring out your time. I already talked about this. Get somebody to come help. Try to have something that stays intact, like your dinner time or your food, right? You guys should be food prepping and not spending all your money at the machines. Protect your family and friends time, even if it's a walk, a bike ride, pizza night. Coordinate that with your co-chief so that everybody has some protected time. Forgive yourself for not getting all the things done and congratulate yourselves for doing as well as you did. Please don't wait on me as residency leadership to pat you on the back once a week. I might remember to do it at some point, and we could not run our residencies without our chiefs. But we don't always take the time to say thank you once an hour, or every hour, to the myriad of things that you guys are doing behind the scenes. So please know we love and appreciate you, but don't feel put upon if you're not told thank you every day. The job can be fun. There's a lot of stuff that's not funny that you just gonna laugh at sometime because that's all you can do. So laugh often. Try to make it appropriate laughter when you have the opportunity. Sometimes you just got to shake your head. It is the same clinically, right? You just walk out the room sometime, you're like, I cannot believe that bull cockamamie that I just heard. You are going to hear that from your colleagues. Let it go. I will tell you, if you didn't think there were bean counters in your residency, guess what? There are bean counters. They're going to go through and count everybody else's weekdays, everybody's weekends. They're going to figure out how much time and who got a Saturday and who got to do journal club after working so that they didn't burn a day. All of those things, you will have bean counters. You got to laugh at them. They spend a whole lot of their life counting beans instead of having a good time. You just got to figure that out. Couple of things, create some time for yourself. Find at least one hobby or activity that's not related to medicine. Talk to your experienced colleagues who have been there. Take care of yourself first. You deserve to feel good. Get a good system in place for checking in with your fellow chiefs and yourself. I cannot say this enough. I've said it 15 times. You guys need to be the biggest, strongest unit of force. You cannot be fragmented as chiefs. You want a not successful year? Become fragmented. It will destroy your leadership. It will destroy your ability to navigate the boat that is your residency program. So get a great system for communication and cohesiveness with your fellow chiefs. That way, when you do need to step down occasionally or you need to put some borders in, your people know you and they say, we got you. Trust your instincts to make sure you are taking good care of yourself, your fellow chiefs, your fellow residents. You guys will hopefully get some additional training on spotting the troubled resident. I'm going out of my lane right now, but I want you guys as chiefs to know that you need to trust your instincts. And we will leave it at that, but you are going to have to look at that. Oh my gosh, we made it to the end. In conclusion, resiliency, wellness, work-life balance, whatever you want to call it, it's a skill set and a mindset that promotes a long, satisfying life and a healthy, productive career. It starts with chiefdom. You guys have already been selected and elevated to do something special. After all the stuff you learned today, you might be doubting that a little bit, but please know it can be awesome and amazing. And you're going to walk away with something that might set you up to do something like me, academics, and be involved with young lives and all of the rest of this stuff. So if you are making your resiliency now, you are setting yourselves up for a much better career later on down the way. Work-life balance also stresses self-responsibility. Self-responsibility. Can't say it again. Help is yours for the asking. Please be communicating with your residency leadership, with your co-chiefs. When you need help, ask for it. And guess what? All of these people, and I think there's only 50 people left, and I think at the greatest part of the day, y'all started with 100 plus. Nobody wants to hear about the wellness, but when they call crying, I hope that you guys can say, you should have listened to that lady because she would have told you how to keep yourself from crying. But here I am to support you. You guys are not alone. Please reach out, create some networks. That's the best and funnest way to make sure your chief year is amazing. I'm so excited about the opportunity to talk to you guys again. Dr. Stahl, Dr. Holland have our contact information. They'll be putting some of this together. We are here to help you and guide you. If you've got some questions and you just need an extra place to turn, reach out to us. We are here to help you be a successful chief. There's a ton of online resources. Look at all of this stuff. Balance, 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 wellness, resiliency. You guys have already demonstrated it because somebody chose you for something special. Have a fabulous and awesome year. And I thank you guys for participating, those that you did, and know for the rest of your life as chiefs, you're going to have your camera on and speak up because it will be expected of you during journal club and conference and all the rest of that stuff. You're going to be leading by example. So we appreciate you guys. Have a fabulous evening. Thank you.
So I have chills because, as usual, Dr. Price inspires me to be a better about a lot of things in life, not just as an educator, but as a person who is kind to myself. So thank you as always for that bolus of well-being and resiliency reminder. We absolutely love having you back every year, Cynthia. So it was great seeing you. And you know, gang, we've got just a couple minutes left, so bear with us. I know we're down to just the last final vital few, but you know, I'm going to share my screen one last time with y'all as we sort of start to wrap this up. And thank you for sticking with us. So the one sort of prompt I was going to say for you guys is to make sure you commit to something now, right? What Dr. Price said is not easy. I can tell you that. I believe I was in a faculty meeting just the other day where I said, I am not a well human. And that's a choice I made, right? That's a choice I make every day. And so you have to really make a different choice. And I'm asking you guys right now to commit to something different than, you know, sacrificing your awe for the program that you have. So, you know, as we start to wrap up, we realized this was a bridge. We realized this was quick. We realized there was a ton to learn today. There is still more. We will be sending you, you guys should be getting contact from the SAEM office about some follow-up sessions that we'll be having on one, the problem resident. You do not want to miss this. How to deal with the resident that is giving you a problem, whether it be from that just schedule pain in your tail to the person who is struggling with addiction or depression or anything in between. Dr. Snow gives an amazing talk on that. And then you're not going to want to miss out on our final session about recruitment and how you can really set the path for your residency and build your legacy as a chief class through really thoughtful recruitment. But before we did, Dr. Holland and I are huge nerds when it comes to leadership. We both like to read on this topic. And so this is an...
Wait. I actually listen on Audible.
That's fair.
As opposed to actually read, because I don't really have time to read, but I drive back and forth to work every day, and that's what I listen to.
But we just wanted to give you our top 3 leadership reads. If you are going to be, you know, aspiring to any leadership role for the rest of your career, this is the greatest preparation for it. And so we just wanted to share what we thought were our top 3 reads. So Carolyn, why don't you take it with your first 3?
Okay, so my picks were Getting to Yes, which is a great book about negotiating. Matt actually had that on his list too. And the thing is to keep in mind is like, yes, but making sure that you know, acknowledge and you say yes, but then you can still pivot. Some great techniques. It's kind of case-based and a good read. My next one is actually Managing the Unexpected. Assuring high performance in an age of complexity. Now there's multiple Managing Unexpected books, all written by the same set of authors, but this particular one, the yellow covered one, covers high reliability organizations and the things that are unique about high reliability organizations. And, you know, those are sometimes hard to do in emergency medicine because there is so much complexity and so much change. But the thing to keep in mind is that there are ways to manage it. And it's not a hard read. We did this in a book club with my medical students who I work with on the quality and patient safety track. So that's a great book. And then my third one, which is, you know, written by a woman and it's written for women, but I honestly think that both men and women should read it, is Lean In. It's a little bit older, but classic. And it really goes into, you know, how women are underrepresented in many of the leadership roles and in the workforce. And so as a woman, learning about how you self-sabotage unintentionally, and on a man, from a man's perspective, reading about how you can help to promote women in leadership roles and mentor them and sponsor them. So I think those are 3 great reads that you can probably get all of them on Audible or check them out from your library on a book on tape and listen to it while you're driving to and from.
Awesome reads. Absolutely. Well, so to turn to my top 3, I wanted to share with you. My first one is called Drive by Daniel Pink. I love this book. My chairman shared it with me when I first got here, and it is definitely altered the way I think about motivating my team. It is hard to motivate people, especially to learn. And so this sort of is the secret behind the 3 pillars of motivation, which is mastery, autonomy, and purpose. It's what we're all working towards every time that we try to really, just be motivated to do anything in our lives, and has really sort of structured the way I approach my residency team. The next is The 5 Dysfunctions of a Team. This is an awesome book by Patrick Laconi. He writes leadership fables. And so this sounds probably weird, and it is, but it is actually a story of how, a team dysfunction is dysfunctional. And I learned a ton about it. Guys, if you're going into education or even healthcare leadership, it's all about teamwork. And this really revolutionized the way I approach my team and my sort of, management strategy. So definitely worth a read, quick, easy read, or listen. And it's kind of fun in the process. It's not as sort of bland as a lot of sort of like nonfiction books often are. And then my last one, which I'm literally just finishing for my book club as we speak, is called Radical Candor. It may just be the flavor of my week, but honestly, it's probably not. It's in my top 3. This is a great book by a woman from Silicon Valley about how to give really targeted, meaningful, direct feedback. We're all too nice in today's world. We all want to pat everyone on the back. And that doesn't mean that we're, and we're not being nice by just saying good job, right? And this book has changed a lot of us. We have a little sort of leadership book club amongst our faculty and has changed a ton of our perspectives on how we need to give really radical candor when we are giving feedback to learners, residents, teammates, anything like that. So great.
And look to see who wrote the comment on the front cover. Sheryl Sandberg, who wrote Lean In.
He references her a lot. They work together. And so these are some great reads. If you got nothing else going on, well worth it. If you're taking a vacation or taking time for yourself, these are some great reads that'll make you a better chief in the process and probably scratch that itch that you're having of, I got to go back to work. You're doing work, you're growing, right? So, in reflection, we're wrapping up. We've just got a couple minutes left. I wanted to share with you the take-homes I'm going to take from today that I kind of wrote down and jotted down as we went. The first is that effective leadership is not a series of quick dispos. We as emergency physicians love the quick dispo. I always say to my residents, ABD, always be dispoing. Not true when you're a leader, right? Not true when you're a leader. Sometimes it's about taking a step back and looking at the whole picture, as we learned from Dr. Davis. Measure thrice and cut once. I think Dr. Betham said this the best in the scheduling section, but there's no question, check, and check again before you come to some sort of conclusion. You've got a team of chiefs you're working with. Check in with them often, check in with them early, and I don't think you're gonna go wrong. Dr. Tui, I think, definitely taught us that the variety is the spice of life. There's no question about that across all of leadership, but especially when it comes to conference planning. When you do a little bit of this, a little bit of that, it is way better than just 5 hours of lecture. And so that hopefully will remind us. Dr. Price's piece that really resonated with me, I think, was asking for help is a badge of maturity, not weakness. Lean into one another for support. It's not just you anymore, right? There's not a single one of you that is solo chief, to my knowledge. I bet it is a team. Lean into that team, lean into your residency leadership, lean into your mentors, and they will help you survive this challenging year. And not just survive, but thrive, quite honestly. Honestly, guys, while I know you're all anxious about the challenges you're about to experience, this is a growth opportunity unlike any other. And I hope you guys are excited about it. We really hope that we've given you a lot to look forward to in this year, and know that you're not alone. We will share, obviously, you can always get in touch with Dr. Holland, or any of the speakers, myself included, and we will continue to try to keep open line of communication if we can be helpful. And that's it. Okay, thank you so much from the bottom of our hearts at SAEM and the Chief Resident Forum Committee. We know this is a rough ride, 4 extra hours of your time on Zoom. My hope is that you are gonna be able to talk this over with your program leadership. I've been building a really nice charcuterie board for my 3 chiefs who are going to come over now and actually discuss further this with a couple of the faculty members. Hopefully you guys can plan something like that too with your colleagues in the near future, and we look forward to seeing you. Thank you so much.
You guys are amazing. Thanks every year for putting together a fantastic program that makes all of our programs run better, nicer, and finer. Thank you. Enjoy your glass of wine tonight, and we will see you shortly. Dr. Holland and Dr. Stoll, you guys are awesome. We appreciate your time.
Thank you so much, everybody, for participating and sticking out for the long day.